room, so I'm gonna give it just a
minute. Kevin Bridge. Yeah, Monique, we had an issue with it, so we had to resend out a new link. That was there was a Zoom technical issue, so we got it fixed though. I'm glad you made it.
All right, we're slowly getting folks on board, so I'm gonna go ahead and start with our housekeeping type items and go ahead with the welcomes and introductions while we still allow a couple of people in. First of all, good morning. Welcome to Bradford Health Services' third education event for 2021. I am Sherry Schaefer. I am the Corporate Director of Clinical Operations at Bradford Health Services, and today I'll be introducing the session and moderating the Q&A portion. I want to thank everyone who's joining us today. Bradford has hosted several of these contact hours since the pandemic began, and we certainly have more planned in the future. So make sure you check our website for upcoming events. I'm also going to include a direct link to our events page in the chat box for you to check out upcoming events. And some of the actual items that our presenters are going to be talking about today will already be in that link for you. So before I introduce today's session, I want to share some important information with you. You are viewing this in webinar format, which means that you can see the presenters, but your video and audio are both turned off. Please use either the chat function at the bottom or the Q&A function also at the bottom of your screen to ask any questions regarding anything discussed or specific questions that you might have for either one of our presenters. At the end of the presentations, we will have a discussion where questions received will be answered at that time. Please note that you will receive a post-session email, including a link to materials presented today. And in that link will also be a link to the video recording of today's presentation. So you'll be able to go back and hear the presentation again afterwards. Today's session is eligible for 3 hours of continuing education contact hours. Bradford is providing those continuing education hours free to you at no charge. After the conclusion of today's presentation, you will receive credit for your participation. Certificates will be sent via email to those who complete the evaluation. Those certificates usually come about 2 weeks after you complete that evaluation. So make sure that you do complete that SurveyMonkey evaluation on today's presentation in order to get your certificate. We were expecting a large attendance for today's session. So your patience in getting those certificates back to you and stuff are appreciated. Finally, if we experience any technical difficulties today, which we already have, please stand by while we do our best to resolve them. Hopefully we've had our major technical glitch and got everybody situated and squared away so we won't have any more interruptions during the webinar. If we do happen to get disconnected, just log back in with the link that you received this morning because that is the newest link. Now that we have the housekeeping issues out of the way, I would like to introduce our session. We're excited for today's session. It is titled Stronger Together, Family Dynamics in Addiction, Treatment, and Recovery. We have 2 presenters today who will focus on the role of family in addiction and recovery. They will share information on family dynamics, motivating participation, and many other topics. Both presenters will be responsive to questions throughout and at the end of the presentation. They'll be discussing more about their backgrounds and our 2 programs that are represented today. Our first presenter is Adam Owens. Adam is a licensed professional counselor in Alabama at Bradford's Birmingham outpatient location. He's been with Bradford for 12 years and began his career as an assistant counselor at our Warrior inpatient facility. After 6 years working at inpatient, he transferred to the outpatient office where he has remained for the last 6 years. So I hope you enjoy the presentation. I will see you again for the question answer discussion following the presentation. And I am now going to turn it over to Adam.
All right. Thank you very much, Sherry. I appreciate that. Again, thanks everybody for being here and participating with us today. This is awesome that we get to be able to give you guys an opportunity to learn more about family dynamics and treatment, but also be able to give you guys free CEUs, which is always a positive. So I'm going to do an introduction of, I guess, myself a little bit more in depth. I'm going to be turning it over as well to Lynn so she can do an introduction as well. And then the way that we decided to do this was kind of, we wanted it to be informal. We wanted us to be able to have just kind of a role. We can play, you know, back and forth off of each other between myself and Lynn. So Lynn's going to be jumping in kind of in the beginning as well. Whenever I'm going through a slide. Towards the end, I wanted to give Lynn, you know, and Lynn with me as well, vice versa, the ability to be able to add something, you know, as things tend to pop up in our heads as we go along with the process. So we're going to be going back and forth. We are going to take a break after probably the first hour and 10 minutes or so, I believe is. So we're going to take probably a 5 to 7 minute break. I know it's tough sitting here for 3 hours altogether. So we definitely want to make sure you let you guys have the ability to get up and move around, get some more coffee if you need to. So, but I'm gonna, I guess, let me jump through here. All right, so I'm gonna introduce myself again. Just kind of, my name is Adam Owens. I'm a LPC here at Bradford Health Services. So, like Sherry said, I have been here for 12 years, coming up on 13 in December, which I'm really fortunate about. You can see the picture of my wife and my son, my wife Sarah, and my son Asher. So he just started kindergarten yesterday, so that was a nerve-wracking experience. But I picked him up and he said, "Dad, I made all these new friends," which was very happy to hear. So so I was glad to get that part done, and now excited to be able to be doing this presentation today. So, but again, I want to share a little bit about me, because I noticed when they put the information out there, they said, you know, we're going to have 2 of our experts. And I felt so like, I was kind of intimidated by that. I was like, wow, an expert. Am I an expert on this? And I was like, you know what, I guess I am. I mean, I've done this for 12 years, working in substance abuse and working with Bradford Health Services. And I'm really fortunate that I have a job that I love. I mean, I really, really do. And I know that, you know, not everybody on the planet can say that. And I say that consistently throughout any of the presentations that I give, is like, I really have a job that I love. I love working in substance abuse. I love working with patients. I love working with families. So I thought about it, like, while I was kind of thinking about my introduction part, right, is what was I going to say? And so I thought about, like, well, what makes me an expert in this topic? One, obviously, being, you know, 12 years of experience working in treatment with families and with patients. You know, but also the fact that I've been in recovery now for 14 and a half years. So my sobriety date is December 22nd, 2006. So if I don't do anything stupid between now and December, I'll be able to and grateful to pick up 15 years. So I've got that side of the coin. The other side of the coin that I have, the experience that I have is with family dynamics. Again, I watched my family go through me going through treatment, but also after I got sober, my father became an alcoholic. And he ended up passing away from this disease back in 2015. So I've had to experience both the role of the addict and the alcoholic, but also from the loved one, right, of somebody who's engaging in that kind of treatment. But anyway, I've been really fortunate. I've been married to my wife now for 12 years. I literally got married, and then 5 days later, after I got back from my honeymoon, I started with Bradford. So I'm really fortunate that I've got somebody by my side that really is awesome and that I love. And I can say that because she's not on here, so I can say it. So I'm not sucking up trying to get points. And then my son is my little mini me. He's my world. He's awesome. It's really fun. I can't describe how much it is. To being a dad is a really cool experience. And so, as you guys can see in the picture, you know, I'm pretty laid back. I'm growing my hair out right now, so that's why it looks kind of the way it does. I'm in the awkward stage right now, so don't hold that against me if you don't mind. But anyway, let me move forward. So just talking a little bit about Bradford Health Services. So again, Bradford, you know, for over 40 years, I'm just going to read this for you guys, but for over 40 years, Bradford Health Services has been innovating and implementing proven treatment for substance use disorders, drawing from best-in-class medical and clinical research. And by incorporating 12-step principles, we provide personalized services that treat the whole person and emphasize the value of continuing care. So again, we're going to list some information, obviously, in the email, so you guys have more information about Bradford Health Services. But we have 2 inpatient facilities. We have one in Warrior, Alabama, which is about 30 minutes north of Birmingham. We have 90 acres out there, which is amazing. It's such a beautiful campus. That's why I loved working out there for so long. There's so many trees out there in the fall, as it's coming into the fall, cooling down, the leaves change. It's so beautiful. It's so relaxing, so peaceful. Patients really enjoy being out there because they feel like kind of in their own world, in their own bubble. And we have all kinds of different things out there. We have a long-term treatment, which is called Limestone Ridge. So where patients can go for long-term treatment. So maybe they go there for, they may have a safety sensitive position that they need to complete, to make sure that they're safe to go back to the public, being nurses, pharmacists, doctors, things like that. But they also patients can do our long-term treatment too, if they have grief and trauma. So we can do EMDR therapy, trauma group with them. If we have patients that have severe chronic pain issues, so we can help them with that. We also have a program now that's more faith-based, which is really great. So a lot of patients find that they enjoy that kind of dynamic mixed in with the program. But we also have, like I said, our regular program that could last anywhere from 21 to 28 days generally. Gives patients a chance to really get medically detox stable, to make sure that they're safe, to give them some tools to begin to start the process and the journey. And then we get them to our different levels of care. And I'll explain a little bit more about that here in a few minutes. But and then we also have a facility up in Madison, Alabama, which is up by Huntsville. So it's a little bit different layout, but still a beautiful area, beautiful campus. And again, great staff. And so then we also have what I work at our Birmingham regional office, which is one of our satellite offices where when patients complete inpatient treatment, they're medically stable, they're ready to go. They transition to our intensive outpatient to where they can do Monday, Tuesday, Wednesday, Thursday. They can do groups. So they'll do a 3-hour group either in the morning or the evening to give them an opportunity. So they pick one and stick with it. But it gives them an opportunity to help kind of transition. And again, that's where we want to include family participation in that process as well. So again, like we have so many different programs. I'm going to talk a little bit more about that as we go through the deal. But I did want to take this second to introduce and turn it over to Lynn for a minute so she can give her introduction about herself, because she's fantastic. But Lynn, so our second presenter is going to be Lynn Wadsworth. Lynn's a licensed clinical mental health counselor at Red Oak Recovery in North Carolina, which is also a very beautiful area as well. She's worked for Red Oak for 7 years and began her career in the family program. And she's also been the director of clinical services, which is her current role. And she's been there for the last year or so. So I am going to turn that over to Lynn.
Okay, thanks, Adam. Good morning, everybody. I'm so glad you guys are here, and I really appreciate folks, just the tolerance for all of us of Zoom and doing telehealth for these last 2 years. I know that we're all a bit fatigued, so I really appreciate you guys being here for 3 hours this morning. And I know that Adam has a lot to offer, and I hope that I have something to offer you guys also. I was inspired by Adam. He put together the PowerPoint and he put the picture of himself and his family on there. And I haven't ever done that before, Adam, by the way, but I was inspired and I thought, oh, that's so fun. And I'm particularly, this is a really big year for me and my family. So I decided to include pictures of my family. And these two, there's me, and then the two pictures are my children and their families. And you can see there's one little one who is not quite a year old. And so that's been really fun this year to watch this baby. For a lot of reasons, it's been really neat. And my stepdaughter, they live internationally. So of course I haven't been able to see them much during COVID. So lots of feelings about all of this family, activity that's been going on and all the family dynamics. What I can say about myself is that I've been a therapist for almost 30 years. They refer to me as an elder these days. And just like Adam said, I still don't think of myself as an expert at all. There are so many people who are such experts, and I don't put myself in that category. But what I do believe is, for me and Adam, is that what you gain over these years is a lot of wisdom and a lot of information. And I am in a place now in my career where I love imparting the information I have to younger clinicians, to other folks who just are not as familiar with family work. So this is a real passion of mine. I'm a licensed supervisor in substance abuse and mental health, and I'm doing a lot of supervision these days. my passion is family work, and I did start the family program at Red Oak Recovery. I was working in a family program and a wilderness program as a family program director prior to coming to Red Oak. So family work has been a particular passion of mine for a long time. My entire career has been spent working with adolescents and young adults and families. So I was always working with families. And then as of about 12 years ago, I started working almost exclusively with families and doing family therapy. And part of what led me to becoming more and more passionate about family work is my son, who is in the bottom picture there with the little baby, was in treatment 14 years ago. And so we all, my daughter in the other picture, and my son was in treatment, and we got to be involved in some very intensive family work. He was in a wilderness program and he was there for 90 days. So we ended up doing 3 different family workshops, and it completely changed our dynamic in our family. And it healed a lot of the ruptures and the wounds that had happened over the years. And what I learned in that process, I understood from books and from learning already, but what I learned from myself more viscerally during that experience is that if we have the opportunity to help heal and change the family, we actually are going to heal the client who is sitting in front of us. And so there's kind of a full circle piece that we try to bring to families, where we help them understand that if we can change some of the family system and some of the family dynamics and also heal some of the old wounds, it contributes phenomenally to the healing of that individual. So it's a beautiful piece that families can do. Families always ask, what can we do? And what I always say to families is, you can do your work, and let's do that. Let's look at what's going on with you and what you bring to the family system. So I love doing this work. I'm very passionate. I talk about it all the time. I'm sure people get sick of hearing me, but I'm super happy to be here talking with you guys about this morning. And so I guess I'll say a little bit about Red Oak also. Red Oak Recovery is a small, private dual diagnosis treatment program that has been open for a little over 7 years, almost 8 years now. And we started 8 years ago with a large campus. We have about 40 acre campuses. So we have these large campuses in the beautiful mountains of Western North Carolina. If you've ever been here, you know what it looks like here. And we started with the young adult women and young adult men on the same campus, and we were treating both of them there, but they didn't interact at all. They didn't have anything to do with each other during the program. I brought the family program and worked with all of the families. After a couple of years, we found a facility for our women's program so that it could have a standalone campus. So we found another 40 acre piece of property that's really beautiful, where we opened the women's program, which is called the Willows at Red Oak Recovery. And we treat young adults between the ages of 18 and around 35-ish, we say. Some of the women tend to be a little bit older than the men that we treat. Our clients tend to stay with us for anywhere between 60 and 90 days. The women, again, tend to stay a little bit longer than the men, but it is a significant amount of time that they spend with us. We are trauma focused. Both of the programs are trauma focused. So we train all of our clinicians in EMDR and somatic therapies. And we also offer a lot of holistic therapies, such as yoga and shiatsu and acupuncture, to also address the trauma piece. In addition, we have a adolescent male program also that we opened much later. It's been open a couple of years, and it is also a small program for a capacity of about 15 teenage boys. And it also has a family focus and a trauma focus, but certainly is much more heightened focus on behavioral issues and specifically substance abuse. So all 3 of our programs are focused on dual diagnosis. So we're treating substance abuse. We're also treating pretty complex mental health sometimes. Yeah, and we have these beautiful campuses here. And if you want to know more about our programs, just let us know. We can let you know as much as you need to know about our programs. And thank you for being here. I'm going to turn it back to you, Adam.
Thank you. I appreciate it. So yeah, and again, you picked some really great pictures. So I'm a little jealous now. I didn't pick the right pictures. But no, this is like I said, we wanted to do kind of like the introduction that way. We thought about initially doing it to where like I would do an introduction, do my piece, and then Lynn do it. But like again, we wanted to be very like kind of code together on this. And again, the idea would be that's what we're talking about here, right? Stronger together. And so that is what we're talking about today in the family dynamics. And so what I wanted to do, and again, I'm sorry I didn't slide this back up here for you as well with Red Oak, but again, the Red Oak is again, it is such a beautiful campus, and again, the staff there is absolutely fantastic. So we get to work with them a lot, so it's really cool to be able to do this together. So we decided initially because of obviously the technical issues, we did have our numbers, participants are going to be jumping in as we go. Like I said, we are going to take a break, probably the first hour and 10, hour and 15 minutes or so. Again, you guys can, if you want to, you can use the question and answer piece on the in the Zoom technology, so that way we can see that. If we can see it and catch it, whether it's in the question and answer or in the chat, we'll try to answer it live if we can. But if not, we're definitely going to make sure that we save some time at the end, a good 30 to 40 minutes, because again, we know that we have a lot of questions. This was something that was really interesting. This was something that came up over the last, I don't know, maybe like 15, 16 months or so since we started with the Zoom technology, was that when we would do different CEU events, we would do the survey at the end, and we would ask, hey, is there any other topics that you'd be interested in? This is a topic that consistently kept coming up. It was about families and family dynamics. And so we, that's kind of what we've been kind of preparing for this for a little bit to get this together. We wanted to be able to host it, for the, kind of this quarter, and to be able to get this information out there. So, and again, I obviously I can't see everybody that's on here, and I don't know everybody's background, but I know that there's going to be some that have, that maybe you're on here for, and again, everybody's on here for different reasons, right? Some people are on here because they want the CEUs, which I don't blame you. Some people are really interested in family dynamics and how to deal with that, because maybe you're working in substance abuse, but you also may, in your field of choice, right, you may not have as much experience with family dynamics, or have more questions about it, or just want to know more about family dynamics and treatment. And so, again, no matter what you're here for, like, we're really just grateful that you're here. And so we hope that you guys get something out of this experience. I'm going to ask you guys in the chat, if you don't mind, if you would just share like one word about how you feel today. And you can be honest, right? Because I mean, when we're in treatment, right, we're doing feelings check-ins with patients all the time. And we always ask that question, how do you feel? But we're generally truly like interested in like, today, in this moment, right here, right now, on a Friday, hopefully for some of you guys payday, right? How do you feel in this moment? All right. So we got some hopeful, tired, no doubt about that, right? Joyful, I saw conflicted in there, annoyed, anxious, ambitious. Okay, cool. Content, a little anxious, delighted, strengthful. Wow, those are good answers. So I appreciate you guys sharing that. And again, you guys can continue to do that. So it's such a cool thing that we sometimes we forget to ask those questions about how are you feeling, and I know that sometimes like we go to the grocery store and somebody asks that question, how are you doing? How are you feeling? And I think we think that they're being polite, and maybe they are, but also, but maybe they genuinely do care. Maybe they really want to know how you're doing. So I wanted to get an idea of how people are doing, and I appreciate everybody has been, and been really honest in there. So some people said kind of uncertain or uncomfortable in this moment, right? Maybe you have some things going on in the back of your mind, and so I hope that you are able to find some peace, and hopefully maybe over these 3 hours that you can, at least take your mind off whatever you're worrying about, and really just kind of zone in. But I really appreciate that. So thank you. So I'm going to ask that question again in just a moment. I'm going to stop share for a second, and then I am going to come back in. I want to play this trailer for you guys, because again, we're here to talk about Stronger Together, family dynamics. There was a movie that came out in 2018, obviously with Julia Roberts, that's called Ben is Back. And this is about the dynamics of a family interacting with their loved one who has a substance abuse issue. So I want you to watch this. And again, you know, even for me as an addict and alcoholic, this was kind of hard to watch because it hit home and it was uncomfortable. But I want you guys to see this, and then we're going to talk about this in a second.
Oh my God, I can't believe it. Hi, Mom. I see you. Is it you? Is that Ben? Did you see? He's gained some weight and he's got the sparkle back in his eyes. He's clearly doing better.
Then why are you hiding everything?
We said we weren't going to do this again, remember?
I agree. If it weren't Christmas, you get a day. This time tomorrow, you are back in sober living.
Yeah, okay.
You do not leave my sight ever. Because for the next 24 hours, you are mine, all mine. Got it?
I got it. He burns. I thought you were dead. I put my family in danger. This is on you.
If I don't deal with this, then it could be worse next time.
Okay. You go in, pay the man, and get right back out.
Lock the door.
Can't be calm.
You need to go home. If you really knew me, you'd be done with
I
me.
know you.
No.
I know you.
You don't, Mom. You don't know me.
Unlock the door, Ben, right now.
I told you not to believe me, and you didn't listen.
Ben!
All I need is for you to do me just one more favor.
I'm looking for my son.
I can tell there's something wrong.
You need to come home.
Not without Ben.
I just need you to please find my son.
The things that I've done to myself and others.
We can't save them, but you'll hate yourself if you don't try. Just tell me, son, where you want me to bury you.
I'm not going to die. Anyways, here I am, still here. So thank you. Thank you for...
All right. Let me come back in here. So I'm curious now that you guys watched that, and I saw some of the comments coming up. As a mother, it's hard to watch, right? Yeah, absolutely. So what do you guys feel now that you've watched this experience? Now that you've watched this trailer? Tearful, triggered, heavy, sad, hope, tense, aware, empathy. Wow. It is. It's so hard to watch that. And some of it is hard to watch, right? Because some of us are going through that. You know, we go through that experience. I know I went through that experience with my father. And it made me also think that, you know, this is what my family went through with me. And so, I mean, imagine that, right? Imagine that if you're just a human being, right? And you don't have any loved ones in treatment, you don't have anybody that's really necessarily dealing with substance abuse on a close level, but you watch that and you see the shift in the way that people are feeling before they watch the clip and then now after they watch the clip. Now imagine being a family member having to go through that. Imagine if you were, right? If you were a mother and you were watching that and you were actually watching that through the lives of your child, or you're watching that through the lives of your spouse or your parent. Whoever wrote that movie, and I never looked it up, but whoever wrote that movie, wow, like they were in the trenches for sure. And it's such an interesting concept, because a lot of times, like, what happens is that we, in substance abuse, we spend a lot of time focusing on the patient, which is true because they're with us, they're in our care, they're with us 24/7, we're watching over them. But sometimes we forget about the families. And I don't think we do that on purpose. I think it's just one of those things that happen. And so I wanted to talk to you guys about, and what I was going to talk about, and what Lynn was going to, we were just kind of go back and forth with this stuff, is that I was going to share kind of the process of this, of treatment with you guys, the process of what it looks like. And again, how we include families into this dynamic in the beginning. And so I'm going to talk a lot more about early treatment or beginning of treatment, pre-treatment, as they're in treatment and they're kind of getting out. And then Lynn's going to cover more of the dynamics of the restorations and things. And so we're going to cover back and forth between the two. But one of the things that I didn't mention earlier was that, Lynn had talked about, being a part of the family program at Red Oak. And then I was really fortunate that I was able to be one of the facilitators for our family program here at Bradford. Especially when I was working at the lodge. So if Tim Hilton, if you guys don't ever get a chance, if you can, please check out the family program that Bradford offers. We offer it right now on Zoom. It's a 2-day program. Tim Hilton does that program, and it is absolutely phenomenal. We have our staff go through that when they come in as a new therapist, really in any new trainings. We want them to be able to understand the family dynamics. So one of the things that I learned about the family program when I taught it, because again, when it was live, it was 3 days in a row. And so we would have them on our campus for 3 days in a row from 8 to 4 o'clock every day. And the last day we'd get them out of there a little after lunch so they could return back home. But what I learned is that families were so frustrated and angry and bewildered because they didn't know what was going on. And so families would show up and they would participate in this deal, and they would be mad. And part of it would be mad at their loved ones, because why would they choose this life? Why would they choose drugs and alcohol over us? Why would they choose to give up their kids? Why would they choose to give up their career, for a substance, right? And by the time the families got through with that first day, the level of understanding and empathy and compassion that they understood was that this is a disease. And so some people say, well, addiction is a choice. Those people who made a choice when they first started using. And truthfully, they did. I did. When I first started using, I started using at 12 years old, and it was a choice. I chose to smoke weed because I thought, this is going to take the way of feelings that I had and take away my anxiety and my insecurities and my confidence and build that confidence back up that I didn't have. And it was a choice. And then somewhere around probably 17 or 18 years old, the choice became non-existent anymore. And I was going to drink and use whether or not I wanted to or not. There would be times where I would be sobbing driving down the road because I didn't want to use anymore. And I knew that there was no way I was going to not. I had to use. And so a lot of what we deal with and a lot of what we interact with families is trying to help them understand that the disease concept is a real thing. Again, the American Medical Association classified addiction and alcoholism as a disease in 1956. And so now we're starting to have a lot more, knowledge and conversations about addiction. But a lot of times before this, we didn't have that conversations. A lot of people didn't even know about treatment. They just didn't know what to expect. And so I wanted to take you guys through the process, right, of what that looks like when somebody comes in there. And somebody asked the question, I believe earlier, about is there any interventions that you have that you can help families get there? And so the first thing that's going to have to happen, one, always, is a crisis. A crisis is always going to occur in the beginning. Okay. Now that crisis could be anything. That crisis could be COVID, right? We found when a significant spike, especially with patients that came to treatment because of alcoholism, because they no longer could hide their drinking because they were at home or working from home, and it became apparent to their family members. A crisis could be an arrest. A crisis could be a loss of a job. Crisis could be health issues. Patients with, different types of, could be overdoses, pancreatitis, cirrhosis, dehydration, all kinds of different things, right? So a crisis occurs, and usually it's a family member, it's a friend of the family, right, that calls and says, hey, I've got this loved one, and they call one of our locations in kind of the main line, and we talk to them, and we talk them through this process. I've got a loved one, they need treatment, they've been drinking excessively, what do we need to do? And so right off the jump, we're usually talking to the families a lot of times first. And we're saying, hey, here's what we do. Here's some of the things that we offer. One of the things that we need to do is that we need to get them in for a consultation. And so we get them in for a consultation. And right now, obviously with COVID, we've done it through Zoom, and we're able to kind of go through that process. But we include the families into that process, because I don't know if you guys know this or not, but patients kind of sometimes tell half truths. When they're doing their consultation, a lot of times they'll say, I have a couple of drinks a night. I don't know what the big deal is. And then you can go to the family and you say, hey, they're reporting, or they may fill out the family questionnaire, and they say, you know, that the 2 drinks a night is filled with 2 Yetis all the way up to the top, and it's liquor all the way up with a splash of Coke. And so like we're learning to, through helping with the family, we're learning to figure out like what the real picture of the story is, because we're not always necessarily going to get it from the patient. Sometimes we do, but a lot of times we want to hear it from the family because they're the ones who have experienced it. They can tell us if the patient has begun to neglect responsibilities, if they've isolated, if they've had trouble keeping commitments. Patients may act as if they're like the happiest human beings on the planet. But then we read into the families thing that they have a significant anger problem. And so that's going to be something that piece that we can take with them and help build the right treatment plan for them in that process. The next thing to do once we get the consultation, right, is that we want to get the right level of care. So you say, okay, well, that's cool. How do you include the families in that? Well, one is that a lot of times families are going to be helping with getting the patients there. They may help with the financial piece. It may be, especially if it's a parent, it's going to be on their insurance. And so we want to make sure that we talk to them about that. And obviously we're talking to the family with a proper, obviously, release in place. That is the one thing that like for sure, like is a necessary piece of the puzzle, is make sure that you guys, when you're talking to a family member, to make sure that you have a release in place. And that's a valid release. That is such an important piece that can get us in trouble when talking to families. Because one thing that's important to realize is that patients have a right to include families on there. They also have a right to revoke that release. And so a lot of times, if I have that release in place, I want to talk to the families and say, listen, your loved one is probably going to go through an emotional roller coaster ride when they're in treatment. And they may have a conversation with you at the phone that really bothers them or irritates them or frustrates them, and they don't know how to process that yet. They may revoke the release. So if you call back and we say that we can't confirm or deny that we have a patient by that name, just know that we're working our best, our absolute best, to get them to include you back on this process. But again, we want to make sure that they understand that's a part of the process. But the level of care, right? So we want to talk to them about the level of care, because again, we want them on board with this. Now, and again, I'm sure Lynn is probably going to attest to this, and other people can probably attest to this too in the chat. Sometimes one of the hardest things that we have to contend with is not necessarily the patient. Sometimes it's the family. Because we have maybe a husband who we're trying to explain to him, you know, hey, your wife needs inpatient level of care. She's drinking this amount, she's taking Xanax and benzo, she's on opiates, she's going to have severe withdrawals. She could die from alcohol or benzo withdrawals. Like, we need to make sure that she's medically stable and safe. And I've got the husband that's saying, like, listen, like, she can't be gone for 2 weeks. She can't be gone for 3 weeks. What am I supposed to do? And so we're having to kind of coach them through the process of like why this level of care is needed. And so we want to include them on this. So they may need outpatient therapy once a week. Maybe they just had like a little issue with their work and we need to kind of address that. Maybe they've been using, but maybe it's marijuana, and so they don't necessarily need a medical detox. And so we need to work on intensive outpatient so we can help them with coping skills. But maybe they do need that long-term, you know, or inpatient treatment of care. We want the family's input on this. We want them to understand like why we're making this recommendation. So we want to get their feedback on this. So then the patient gets settled in. So let's say they get an inpatient, they get settled in, right? So again, as long as we got a release in place, within that first 24 hours, we're calling that family and we're talking to them and we're saying, hey, listen, you know, your loved one got settled in. We want you to know that they're here, they're doing great, they're safe, you know, everything's, you know, going as planned. Their counselor is going to be this person, and you're going to get a phone call from our family program staff, because we want to include you into the family program. We want you to be a part of this process. On the outpatient level of care, on the intensive outpatient level of care, I typically will call families once a week. In that first week, I just say, hey, I just wanted to let you know that I'm going to be working with your loved one. And then I want you to know who I am. You know, I want to be able to give you my direct line. I want you to be a part of this process. You know, do you have any questions? Do you have any concerns? And that's such a great thing together for us to work with as clinicians, to work with families. And they can say, hey, you know, yeah, they're back at home and they're starting to, you know, they're starting to talk to that old friend again. Because again, patients aren't going to tell us this information sometimes. So our families are going to be one of our biggest advocates to help us with this process. So I'll tell families, hey, please, if you see anything, you have any questions, any concerns, please let us know. by the way, were you able to attend the family program? Oh my gosh, I did. It was so wonderful. Like I felt so empowered by the time I got done with this. Or, you know what, I haven't had the chance to do this yet. So I'll either include information to the family program and get Leslie, who makes kind of the phone calls and gets everybody scheduled. Or I may say, hey, you know what, I'm gonna email your loved one today. I'm gonna email them a copy of the Broken Brain recording that we did. If you guys, some of you guys may have been here in the last CEU last year where I did the Broken Brain. If you get a chance, watch this if you can, right? And it gives them this opportunity to include themselves in the process so they know what's going on. So I wanted to touch base on that. Lynn, anything on this that you wanted to maybe reiterate? And
yeah, the only thing I would add, Adam, is that, and you're really speaking to this, I don't know if you said this term, I may have missed it, but one of the things that we say to families when they arrive to treatment with their loved one is really that they have been through trauma also. So it's a traumatic experience for you to watch your loved one suffering and struggling and going through so many difficulties. And, you know, that experience of you're afraid every time the phone rings, or, you know, afraid to go to sleep at night because you're waiting for them to come home or something. And so that really creates almost a traumatic response for the family as well. And I know a lot of parents, when I've said that to them, have kind of breathed a sigh of like relief and go, you know, thank you so much for understanding the intensity of what I have gone through also.
yeah.
So, yeah.
Yeah, absolutely. Yeah, thank you. Yeah, thank you for adding that too. That's a great point. And while Lynn was sharing that as well, I was going through and looking at that. And so I saw the question from Amitria, and I'm going to try to answer that here in a little bit as we go a little bit farther. Hopefully it'll answer. If not, I'll definitely go back and talk about that, the question that you wrote. And then Lindsay, your question about what is the broken brain. So the broken brain is, again, it's our lecture that we do with our families. And again, the patients actually get to see the broken brain as well. A lot of times either Tim Hilton will do it while he's alive at the facility, or again, we'll use one of the broken brain links that I have. But basically it is about the science behind addiction. So it helps patients learn about like why they do what they do. Because a lot of times my family would ask that question. They'd say, why are you doing this? Like, why do you keep doing this? Why are you drinking and using? And again, why are you causing all this damage even when you know it causes everything in your life? And my honest answer was I had no clue. I didn't know. And then I began to see the science. Now, again, the science behind it, and again, we talk about like dysregulation, we talk about what causes like gaps in the neurotransmitter pathways, which shows specifically why. You know, why that is the way that it is, like why it could be anything that causes that gap to form. Could be because of, again, long history of drug and alcohol use. It could be because of blunt force trauma to the head. We found that what causes that gap to form that creates the addict alcoholic part of the brain is a temperature of 105 degrees for more than 2 days. And most people would say, well, I've never had a 105-degree temperature for more than 2 days. But if the patients have ever done ecstasy 2 days in a row, they did, because ecstasy sends their brain up to 107. And then also PTSD. But again, we have PTSD with military men and women, again, who have experienced things in combat. You also have first responders. And again, that's why we're trying to, when we're talking to the patients, we're trying to get the biggest, best picture that we can come up with so that we know how to help them. Because again, if we don't know, you know, if we don't know certain aspects about them, but their family, because they're not willing to share it, but their family's willing to tell us that, hey, they went through an abusive relationship when they were younger. Hey, they watched someone in their family that was really important to them pass away. Then that helps us understand that, hey, they may need a trauma group, and maybe they can't afford it, or maybe they can't stay long enough to do the trauma group, but that at least helps us get the right referral and resources for them when they do leave the treatment program. But I think it's so important for us, like I said, to acknowledge the fact that like this is a process for families. So again, why include family members? Again, that's the big question. One is to gain, like I said, collateral information. Patients aren't always going to be honest with us and upfront. And again, patients' brains, you know, I mean, again, if you work in substance abuse and you've been around addiction, alcoholism, especially when they're coming off of substances, like their brain's foggy. They don't always remember every little detail that they're supposed to tell us. They can't always remember like every little thing that's happened in their life. That's why we do a consultation with them. Then we do a nursing assessment. Then we do the doctor's H&P. Then we do the psychosocial assessment. So they get really tired of answering the same questions over and over again. But you know what? You find that like every time they answer, like a lot of times, like you get closer to the truth. So we want to gain that collateral information from our families. They can tell us a little bit about, they may say, oh, a patient may say, well, this has only been bad for a year. This is when this thing happened. And the families may say, no, this has been going on for like 10 years. The patient may not tell us that they've been to treatment before. Maybe they didn't go somewhere with us, but maybe they went somewhere else and they left that piece of information off. So then we can kind of get that information from them. The other thing that we include, and why we include families, is to gauge level of support for recovery. Again, it sounds baffling about this, but this is a reality. There are family members who are not that sometimes supportive of their loved one getting better. Some people say, well, well, hold on a second. Why would you say that? Well, the reality is because sometimes the loved ones in the family have the same problem. We've had it in the family program where we've actually had someone come to the family program, and this has happened a couple of times, where in the midst of the family program, one of the persons pulled us aside on the break and said, I think I need treatment. I think I have a problem. Because what we were saying really hit home to them, and they got this sense of moment of clarity. And in fact, in a couple of times, we've actually been able to get someone to one of our different facilities, or we were able to get them to another facility just because of they were drinking and using the same amount with their loved one. And so a lot of times they may want to be distant because, again, if this shoe fits for my loved one and I'm using the same thing, it's going to fit for me. That's uncomfortable. Sometimes families don't want to show up, and a lot of times, sometimes the parents don't necessarily want to be present and a part of this because they think they did something wrong. I tell patients all the time, and I tell families all the time, listen, did I grow up in a dysfunctional household? 100%. Did my family make me an addict and alcoholic? Absolutely not. You know, nothing families did that made me that way. I mean, like, was there signs out there? Maybe they could have got me help a little sooner. Sure, of course. But nothing my family did that would have changed any of that stuff. And so my family didn't cause me being an addict and alcoholic. I made a choice in the beginning, and it was my choice alone. But families, a lot of times, that's the one thing that they're like, I don't know. I mean, like, I feel like I did something wrong. And it's like, listen, no one's perfect, but you didn't do anything to cause this. But again, some people don't want that level of supportive recovery. Their families don't want anything to do with it because they think that treatment is hocus pocus. They think that, their loved one's just trying to get away for a vacation. If they really want to quit, they'll just stop. And so we're trying to gauge that level of support that they have, because again, that level of support that they have is going to determine what recommendations we make after that. If they don't have any level of support, then we're not going to send them right back into that household, right? We want to make the right recommendation. Maybe we say, hey, you need to go to sober living, or hey, we need to think that maybe you need to stay a little bit longer here. So we use that to gain that. Again, we want to assess barriers in the living environment. Maybe they have a household with people that they're using with in the past. Again, we're wanting to cross-check the patient's account of events and measure insight into severity. So again, we want to see what the patients are actually like. Are they a good historian? Is their depiction of the picture accurate? We want to get help with treatment planning. Again, maybe the patient says nothing about anger, but the family says, no, they definitely have an anger issue. Like, I'm literally patching holes up at the house right now, or we've literally had to buy the same smartphone 3 times because they've smashed it. And so I can take that to the person and say, hey, listen, like, what's going on with you? Do you ever think that you have anger issues going on? Like when you feel like you're just so frustrated, right? And I can spin it to where like it gets them a little bit more open to talk about it. But that's going to be helpful for me to do that. Maybe the person has an issue with spirituality and their family is able to give me that information. I want to be able to use and incorporate that family into the process. Because I'll tell you what, when you include the family into it, they feel so much better. They feel a part of the puzzle. They feel like they're there to guide us and help us along the way. And they feel a part of this thing. Because again, the family's already lost anyway. By the time their loved one gets to treatment, they're lost anyway. They have no clue what's going on. They don't know which way's up, which way's down. And so this is a way for to incorporate them into them. And again, we're starting that process of empowering them. Again, we also want to build alliances, right, that prevent discharge and prevent AMAs, right, against medical advice, because patients, the moment they start feeling better, or the moment I feel better now, listen, I got to get back to work. I got to go back to work, or I got to do this, or I got to do that, or I just had an argument with this person. I need to leave because I need to take care of it face to face. We can use that, again, with that release in place, we can use that and say, hey, listen, they're going to probably try to get out of here sometimes sooner than they should. We need to make sure that you guys are on the same page. Do not come pick them up. You cannot come pick them up, because again, this is something that's good. They need to be able to complete this. They're going to feel uncomfortable, but just know that, like, we got them. They're in a safe place. Let them be here. And so the families kind of know that on the front end. We also want families, because we want to include the families in the family program, because the families, they come to the treatment and they think, well, here we're going to talk about our loved ones. But what we end up doing is we end up talking about families. We end up talking about what they're going through. We want to help them process their feelings. We want to help guide them in how to communicate with their loved ones. We want to help guide them in how to set boundaries, because they don't know sometimes. They don't know how to set those things. And so we want to be able to include that. We want to provide education, obviously, right? I mean, like with the opiate epidemic, the way that it is, we want to talk about families. Hey, when they leave this treatment facility, they are going to have, if they're an opiate addict and they have an opiate diagnosis, they're leaving with a prescription to Narcan here. So we need to let you understand hey, this is what overdoses look like. This is what Narcan is. This is how you use it. So we want to give them, again, if the loved one, comes home, we still want to have them as empowered as they possibly can. We're not trying to scare them, but we want them to be ready for any possible thing that they could come up with. And then the last thing is that we want to set the stage for aftercare, because, and again, Lynn May can speak to this as well as others. A lot of the things that we're dealing with when we're talking with families is that we're trying to incorporate them and let them understand that, hey, by the way, treatment is not a one-stop shop. When they come to treatment, this is the beginning of the process. There's still the intensive outpatient where they come 4 days a week. There's still the aftercare that's really important. Treatment is like surgery, and the aftercare, like the 12-step meetings, going to IOP, getting the sponsor, that's the physical therapy. And anybody who's ever had surgery, you know that the surgery is great and the surgery is wonderful, but if you don't follow through with the aftercare, you're in trouble. And you're honestly going to get yourself hurt in a lot more ways. So we want the families to know from the jump, hey, listen, this isn't going to be a one-stop shop. They're not going to come here and then just leave here better. Okay, there's things that they're going to need to do. And so we need the families to be on board with them, because we're going to say, hey, they're going to be going to IOP, for probably 4 to 6 weeks, on average, for 4 nights a week or 4 mornings a week or whatever. And so, we need you guys to know that. So if they try to tell you, I don't have anything else to do after this, that we're on the same page together. Because again, we don't want your loved one to come back to treatment. We don't want them to keep coming back. We want them to get this right the first time, so that they can go live a happy, successful life. Lynn, anything that you could think of as far as including for families? Okay. Very cool. I'm just kind of looking through that. Okay. Let me jump ahead, and again, let's just talk a little bit about how families are affected. One of the reasons and one of the things that why families are needed to be a part of this process is because families need to heal too. This disease affects everybody. I mean, you saw that in the movie clip and in the trailer, but it's an accurate depiction of what it is. The whole family is divided, because again, you've got the impact on children, right? Because again, if children are a part of the process, if children are a part of the scenario, right? A lot of times, and it's not meant to be that way, but a lot of times the children are neglected in a way because the family is so immersed in the other person. Maybe it's the older sibling, or maybe it's the spouse, the wife or the husband are so focused on that person that the child in some ways gets neglected. There's also an impact on the child because the child is paying attention and watching this dynamic, and they're seeing a model that they don't necessarily need to copy, right? They're not learning that it's okay to talk about their feelings. They're not talking about these things because a lot of times families just kind of, I don't know, we just, if we don't look at it, it's not there, right? And so we just kind of learn how to ignore things and not address it. And so there is an impact on children. And so we need to be able to make sure that, especially for the other kids in the house, that they can have the focus kind of shifted back to them when the loved one comes to treatment, so that we can, kind of get that back on track. Another reason families are affected is loss of trust. Again, trust happens when your words and your actions match. And as families will tell you, that hadn't happened in a while. And so what ends up happening is that there's a loss of trust. There's usually families have live 365 on their phone, and they put the live 365 tracker on their loved one's phone because their loved one says, I'm going to work, but they're not really going to work. And they know that because of all the things that's happened before, that now they want to know, they want to know what they're doing. So there's a loss of trust. They can't trust what the person says. I've even had a patient's family call me and say, hey, they told me that today that you guys talked about the topic of blank. Is that true? And I go, yeah, actually we did today. We did talk about that today, and I may give them a rundown of like some topics we covered a little bit in group that day or that week. But there's definitely a loss of trust, and families are affected by that. And that loss of trust affects other people. They begin to lose trust in others. There's an increased stress, obviously, from a standpoint of the families are completely stressed out. They have no clue what it's like to be able to walk into their house and be able to relax. They don't know what that feels like, because the moment they come home from work, or the moment they come home from this or that, it's like they feel like they're walking on eggshells. We hear that all the time. I feel like I'm walking on eggshells with my loved one. And so there's definitely an increase of stress. It could be a financial stress. It could be because of legal issues. There's more stress. Again, the financial problems, because again, depending on the substances and how much they're spending, that could be a big deal. Maybe they're not paying bills the way that they said they were. And so we're helping families understand some of the financial problems that come with addiction and substance abuse. There could be physical and emotional abuse. Unfortunately, that is a part of the process sometimes, where there is a level of abuse that shows up because of substances. And so we have to talk to families about that and let them understand that, listen, that behavior that's not okay. That is not an acceptable behavior regardless, And so we want to help them understand that, one, that they're not alone. And we want to help get them the support that they need, because they're hurting. They have no one to talk to. Addiction isolates not only the addict and alcoholic, but the families, because they have no one else to talk to. And so one of the things that we found in the family program, and again, Lynn probably saw this as well, was the fact that the family program gave people a chance to interact with each other and go, oh my gosh, I thought I was the only one. Oh my gosh, I thought we were the only family going through this. I've had no one to talk to. I couldn't even tell people at my church. I couldn't tell other family members. So it's just a lot. Go ahead. I saw you jump in, Lynn. Go ahead.
Yeah, I was just going to say that, we have intensive family workshops just like you guys do. And while parents are extremely appreciative and they really grow from all of the work that we do in the workshop, almost every evaluation says one of the most healing factors was being in the room with other families who are going through the same thing. So it really speaks to the isolation that people feel, and just the level of stress that's caused because of the isolation. So it's really a beautiful thing. And I think the more in treatment, the more we can bring families together to support each other, the healthier all of our families will be, right? We're always looking for new ways to bring families together, whether it's phone calls or whatever it is, Zoom sessions, whatever. But yeah, that's really important.
Yeah, absolutely. Gabrielle, thank you. I put, it was my phone. I don't know what I'm getting like tons of messages about, but I put it on the floor so that way it'll do that. So I apologize about the vibration. And then so again, great. So I'm seeing some questions here. How do you deal with the stress level? How do you approach a family member with a question without being judgmental? A lot of times, like what we do, especially in the family program, is that we're talking to them about communication. That one of the things that we want that will immediately shut down a situation with their loved one is to be accusatory. So accusatory conversations could be like, you must have already relapsed already. I mean, you're already back in your room, you're isolating, you're already blah, blah, blah. It's kind of like that accusatory conversation. I mean, why aren't you going to those meetings anymore? I mean, you think you're better now? And it's like, and not necessarily that it's always that kind of aggressive, but it does show up sometimes where it's like that. So what we tell them is that we don't want to be accusatory. What we want to share with them is observations. So instead of me saying, hey, you're already in your room, you're isolating and you're not calling your sponsor anymore, you're not going to meetings and blah, blah, blah. Like you're probably already relapsed. That's accusatory. That's going to be defensive. That's going to get that person immediately on a no contact with you list already immediately. But what I could say was, I just wanted to check in with you and see if you're okay. I noticed that, you used to go, and Tim Hilton does this a lot as well. He used to say and I used to notice that you used to go to your meetings and stuff, and I noticed that you're at home a little bit more at nighttime and stuff like that. I just wanted to check and see if you're okay. And if I do it that way, even though the answer may still be, no, everything's fine, I'm good, right? It opens the door. What we found was that it opens the door for them to, because they feel like we're on the same page and we're on the same team, that they're willing to come back. And again, I may have that conversation with the families of like, hey, don't have this conversation when you're emotionally charged about it. This isn't going to be helpful, because again, if I go into it emotionally charged, it's already going to be a disaster. And so I'll share with you guys this real quick, is that I do this activity with patients a lot, and I've used it with families. It's been really awesome. Is we have these building blocks, right? We have about 20 pieces. They're all different colors and shapes and stuff, but we have 2 sets. So everybody has the exact same. And we sit 2 tables up, and they sit back to back. One person is the instructor. So the person is going to build something with all those blocks. They're going to describe it to their partner. They're going to say, hey, I put it this here, I put this block here, this one, blah, blah, blah. The other person is the one who is the listener. The only thing they can say is okay. That's it. That's the only thing that they can say is okay. Now we explain to them, hey, change your inflection can change the whole dynamic of the conversation. So if they say, hey, put this blue block here, you can say, okay. And that's confident, right? But if they say, okay, that means that person needs to readdress like how they describe that experience, or where they put that block. Do you know where like the building design usually gets off? From the very first move. Because they say, I'm going to put the blue block on the table, but they don't say whether it's to lay it, standing straight up, or if it's flat against the table, or if it's a rectangle, if they're going to put it that way or long ways, right? And it gets off on the jump. So we say that a lot of times when we do that with families, and I'll do that sometimes with families as well, and have them do that activity and say, like, listen, like sometimes we need to like process like what we want to talk about. Sometimes we need to journal what we need to talk about. Sometimes we need to meditate before we talk about whatever this situation is, so that we're coming into it calm and clear and concise, not accusatory, but pointing out observations. And so that I appreciate that question. But something else that comes up a lot is fear and confusion. That's the other thing that comes up a lot. Families are afraid. I know my family, because again, I was in treatment for Christmas of 2006. I know my family was terrified. They were happy that I was there, and they got good sleep while I was there. But every second that went by was a second closer to me getting out of treatment. And now what's going to happen? And that's why having them a part of that process of knowing what the plan is after they get out, including them into the process of like, hey, can they go to sober living? This would be a great opportunity for them to do this. This is why we think sober living would be helpful for them. So we want to do and talk about that idea of the fear and confusion, so we can help them. So just kind of going through a couple things really quick, which is interesting, is that, and some of y'all probably recognize the old DSM-4, right? Y'all remember that thing? Holy cow, we had that for a long time. We now are fortunate we have the DSM-5. So you're like, why would you use this? Well, we use this in the family program piece, and we still use this in the family program piece, because this is where we refer to this process as called the turn. Okay. And this is one of my favorite pieces that we do. And again, I cannot stress this enough. If you get a chance, go to the family program and watch Tim Hilton do this, because it will leave you like just blown away at how he does this piece. And I can't do it justice, so that's why I'm directing it to him. But we go through, when the second morning of the family program, we talk to them about levels of care, treatment, right? So why we recommend outpatient, why we recommend intensive outpatient, why we recommend our regular PHP program, why we think that they would benefit from the extended program, whatever it may be. And we say, hey, this is from the DSM-4. And so this is for chemical dependency. In order for them to go to treatment, they have to meet 3 of the 7 criteria. So we go through the 7 criteria with them, right? So we say tolerance, right? So their tolerance is built up. They're using more than they were before. They have withdrawals, right? Withdrawals could look anything, and we kind of explain the, the process of withdrawals, what it may look like, so we talk about opiates and then benzos and things like that, all the different withdrawals that show up. Taking larger amounts over a long period of time than was intended. So maybe they say they're only going to have 2 beers at the function and they end up just getting trashed. Unsuccessful efforts to cut down or control their use. So maybe they've gone to treatment before, maybe they've gone to a 12-step program before, maybe they've done all these things and they've tried. Maybe they've only bought enough, a case of beer and that was it, right? Maybe they tried to make their prescription last. So that would be some of the things that we reference. Increased time spending obtaining substance and recovering from effects. So maybe it's because like they're going in the middle of the night to go get whatever they need to get. They're having to go back and forth to the liquor store. They're having to take time off from work because they're too hungover or they're sick from withdrawals. They give up activities because of their use, things they used to appreciate. So maybe they attended church. Maybe they're not doing that anymore. Maybe they played basketball, or maybe they worked out. Maybe they used to write. Maybe they used to play music. Now they don't do those things. And then continued use despite physical or psychological consequences. So even after they've gotten arrested, they're using, even after treatment, loss of relationships, whatever, bank account, whatever, they're using. So we go through this list. We say, okay, how many people could relate that their loved one has one of these things? And so of course, everybody raises their hand. How many people could see that their loved one meets 3 of the criteria? Of course, everybody raises their hand. 90 to 95% of the family program participants are going to be able to raise their hand for all 7 of these. So we take a quick break. So then we come back in and we say, hey, let's go through this list one more time. And we go through this list. And instead of us talking about the addict or alcoholic and their substance, what we find is we talk about the family members and how their loved one is their substance. Does that make sense? So we're beginning to talk to them about how, have you guys noticed over a period of time that your tolerance has increased? Have you noticed that you begin to tolerate behavior that you normally would have never tolerated before? Maybe the way that your loved one's talking to you, or maybe the way that your loved one's treating you. Have you noticed that you've tolerated that a little bit more? Do you ever feel like you have almost kind of withdrawals, right? I mean, like, when you don't hear from them a while, like you're checking your phone, you're feeling those phantom vibrations. Do you notice that, when they're supposed to be home at 6:30 and they're not home at 6:30, that you're going to the window, looking back and forth, kind of pacing back and forth because you're nervous, because you can't sit still, because you're wondering if they call? Do you ever notice that that you spend more time trying to control their behavior than was intended? You're like, I'm just going to put the phone tracker on there just in case I just need to track them every once in a while. And then you're literally like looking at the phone nonstop, seeing where they're going. Have you ever noticed that you've had unsuccessful efforts to cut down or control their use? Again, like, have you ever gone through like have you tried to hide some stuff from them? Have you tried to hide access to things? Have you checked their Facebook page and seen what they're doing, their TikTok, right? And see what they're doing, what the kids are doing these days? Have you increased time spending obtaining, and watching over your loved one? Have you had to miss work because of it? Have you missed events? Have you missed functions? Have you given up activities that you used to enjoy? Maybe you used to like to go to the gym and work out, but now you don't want to leave the house because you're so afraid of like, what happens if I leave and are they going to die? Are they going to overdose in the floor? So you don't even leave your house anymore. And then have you continued to monitor and try to control their use, even though it's had negative impacts on their families and an impact on you? And you just see the room just drop. And we tell them, you guys thought you guys were here in our family program for your loved one. Now we're in here to talk about you. So for the next day and a half, we're talking about you guys, and that's it, because what happens is, and we give the example of, it was in Brazil where a bank robber took a little girl hostage, right? And the mother was outside watching this whole experience. He grabbed her from the mother and watched and was doing that. And so the kid was being held hostage, and it was so terrifying, right? Obviously, to have that experience. And so finally, they were able to, the hostage negotiators were in there, but this mother watched her child, be hostage for a few hours. And so when they finally got the little girl back to her mother, and they got her checked out, they said, listen, we're going to make sure that we get this little girl set up with counseling so that she can process through this, because this is a lot. And oh, by the way, like, we're going to help you get treatment too, and help you get therapy as well, because you've had to watch your loved one being held hostage by their substances. And it's such a powerful moment. Like, there's very few dry eyes in the house. And a lot of times, even for me, like, it was really hard for me to have a dry eye in the house, because it was just such a powerful moment for them to be able to see that experience. And so that's why we talk to them about like why it's so important for families to have this moment to come through there. Lynn, anything on this one that stood out to you?
No, I just want to affirm and agree everything you've been talking about. Yeah.
Thank you.
Adam, before you move on, can you
Yeah.
describe the peanut butter and jelly exercise? We've had a lot of questions about that.
The peanut butter and jelly exercise. Oh, I don't remember that. Did I say peanut butter and jelly?
I think someone in the chat box mentioned it.
Ooh,
So I actually don't know that exercise either. I wrote down peanut butter and jelly exercise because I'm going to look it up also.
holy cow. Like I'm going to learn something new today. I'm looking back up at it and I'm just like, yes, it was, I think it was Amanda put it in there. Yeah, that's awesome though. Amanda, if you'll put that in there, because I don't know about that. I don't have to use that for my own future reference. So once we talk to the families though about this stuff and we kind of get them understanding that, hey, you guys are going to need treatment as well. Like we want them to understand that there's a process that they're going to have to take as well. So two things that we reference a lot of times is two amazing, wonderful books. I cannot stress enough. One is Boundaries by Dr. Cloud and Dr. Townsend, and Codependent No More by Melody Betty. So I'm sure probably some of you guys in this webinar have probably owned this book, have probably read this book, but this is a crucial part because families don't realize a lot of times that they are codependent on their loved one. They have no clue that they're codependent on their loved one. And you say boundaries and they're like, what is that? I used to do this exercise when we were talking to families where I would come in and I would purposely on the break when we'd come back in from lunch or something like that, I would purposely untie my shoe. And I would usually do it. And I would purposely go up to a mom. I knew that was a mom. And I would say, hey, Miss Lynn, hey, could you do me a favor? And I would stand there and I just say, hey, Miss Lynn, could you tie my shoe for me? And I'd kind of put my shoe up on the chair in front of her. And 100% of the time, those moms would tie those shoes. And they were like, well, I was like, why are you tying my shoe? And then she said, well, you asked. Yeah, but I'm 38 years old. There's nothing wrong with my back. There's nothing wrong with me tying my shoe. I literally just got you to do something. And so now we start talking about that codependent piece. What's really funny. And again, I just thought about this, but it really is funny is a lot of times, we say, we'll ask families, we'll talk about like that codependent piece part, right? And boundaries. And families will say something like, well, what are we supposed to do? When they get mad and they grab their keys and they grab their phone. You know what my question is? Who pays for the car and who pays for the phone? And a lot of times it's the family. The family goes, well, we pay for the phone. Cool, shut it off. What? Yeah, shut the phone off. It's your phone, by the way. It's not their phone. They have this sense of entitlement that they think that it's their phone. Like, you got to shut this off. And they go, oh my gosh, I mean, I don't even know how you do that. How do you do that? And I go, let me explain. Here's this really wonderful book. It's called Boundaries. And they go, what's boundaries? And so we talk about from a real basic standpoint about like a yard. A yard is yard and a fence is a boundary. And so again, like if you guys are in Birmingham area, you guys know, if you live in Mountain Brook area, you don't need like, a 10-foot tall, fence with razor wire and 2 Doberman pinchers like in the backyard, like to protect yourself, right? I mean, that's a little extreme for Mountain Brook, right? So you would put like, a little fence on there, just a little something that looks kind of nice, curb appeal, whatever. And so like, a lot of times families are either setting like too high boundaries or they're not setting boundaries at all. And so like, we're trying to help them find the reason of like, hey, boundaries are empowering for you guys. Like, and they're like, well, wait a second, what do you mean boundaries are empowering? Boundaries are empowering for you because you get to control not your loved one, but you get to set a sense of safety and security for yourself. I have a boundary at my house, you know, and my wife and I, we have this boundary where, because both of us are in recovery, like we don't want drugs or alcohol in our house. It's, again, if we go to your house and alcohol is there, cool, that's great. But at our house, we don't want it because we just don't want it in our house. We're both in recovery. It's not like we're going to drink today, but we just don't want it. That's a boundary for us. And we set that, and the people that know us, like, they respect that. And so, like, you know, I may say a boundary, and I may tell families, you know, boundaries that they can set for their loved ones is, hey, if you don't complete treatment, you can't come home. If you don't follow the recommendations of your loved one or the treatment team, you can't come home. You know, and so, like, if we're going to financially help you, then you need to go to sober living. You know, and again, we're not trying to control them, because ultimately we're giving them the ability to make their own choice. But these two books are absolutely, and again, even if you don't work in substance abuse, these two books can be life-changing, because some of us, right? And again, I'm saying some of us because I'm including myself into that. Some of us grew up in a house where we grew up in a codependent house. And we also grew up in a house where we didn't boundaries. What is that? So I think it could be a really important text. But go ahead, Lynn.
I was just going to add that one of my favorite books also is Melody Beattie's The Codependent's Guide to the 12 Steps. And I don't even know if there's a new edition or how recent it's been published again, but I know that it's available used on Amazon or online in different places. But it's one of those books that I often will also recommend parents just keep next to their bed and read it here and there, you know, instead of trying to read it front to back, just to keep it as almost like their own little support system.
Mm-hmm.
So yeah, just wanted to add that.
And by the way, like, I'll tell my patients, hey, by the way, I've recommended that your family get the book Boundaries. And you just hear them go, oh. And I go, oh yeah, oh, it's happening. They're about to get a black belt in boundaries. And they're just like, oh, why did you do that? I'm like, well, because you need them. Because you're 30 something years old, you need boundaries. You know, it's like, I need to set boundaries with my child. But again, I didn't know how to set boundaries. I didn't know what boundaries were. So I had to learn how to set those by, again, reading some of these books that are out there. So I hope that you guys are able to, again, pick that up and check that out. The other thing that we want to recommend, and I'm getting closer to my end of my part, and then we're going to take the break. But one of the things we also recommend is Al-Anon. So Al-Anon, and some of you guys may not know what Al-Anon is. Al-Anon is the 12-step program for friends and family of loved ones who have substance abuse. Okay, so they get to go to a 12-step meeting, okay, for themselves, and they get to get a sponsor just like their loved one does. So when their sponsor goes and gets a sponsor and works the 12 steps, the family members, the moms, the dads, the wife, the husband, the siblings, the children, adult children of alcoholics, right? ACOAs, they get to go there and get a sponsor. They get to work the fourth step where they write about their resentments. And so Al-Anon has been crucial. And again, Al-Anon you can catch on Zoom. Al-Anon you can catch live in your city. But again, I thought this was an interesting stat from that they released from 2018. So how many years of continuous attendance? Members have on average attended meetings for 14 years. So they find it to be extremely helpful, obviously. 24% have attended 3 years or less. 25% have attended 4 to 9, and then 51% have attended 10 plus years. And then 99% of the family members that go in there have attended 1 or more meetings per week. 58% have attended 2 or more meetings a week, and then 13% are attending 4 or more meetings per week. So what that tells you, hopefully, is that Al-Anon is an absolute great resource for families, because they go in there and again, they learn how to empower themselves. They learn how to talk about and process stuff. They learn how to go through their resentments and their fears, and they work on their spiritual connections. But what they do is that they find that they have a place and a sense of community where patients and clients come into treatment, and they find that they have this sense of connection and community with their family, with their people in their treatment centers and IOP and their 12-step meetings. Their family members can have a safe place that they can go for an hour where they can go and talk about what's going on with them and feel connected and feel safe. And that's such an important part is for the Al-Anon. And then one of the last 2 slides that I've got is building a team. That's what we want families to do, is be able to build a team. One of the things I talked about was the impact of the financial stress because of that. I talk about with my patients all the time, the Dave Ramsey program. They get tired of hearing about Dave Ramsey sometimes, but they also now have, let's say an average of $50 a week, or if they're using opiates and other substances, they may have an extra $250 a week that they were using on substances that, okay, well, what are you going to do with that money? So where's that money going to go? And if y'all know, and again, finances is a big piece of relationships that cause fights in relationships. So I want the loved ones, I want the family members, I want the parents, I want the family, the spouses, you know, and even the kids to get into a good model of like being responsible with their deals. So we may talk about what that looks like. And the idea is not about like the financial piece necessarily. It's about communicating with each other, building a team. So you're transparent. Hey, I'm going to go buy that thing. Is that, it would be okay if I bought that thing? You know, I thought about doing that this week. Hey, I was going to put, you know, X amount of dollars towards this. What do you think? So they're getting a chance together to work together as a team, because for so many families, they haven't been on the same team for so long. They feel like they've been on opposing forces with each other. So this is one of the ways that I found. And so like, again, I did the Dave Ramsey program. My wife and I did it about 5 years ago, and it was the most amazing thing. I told my coworker that's sitting in the office next to me, Adam Johnson, about it. And so he did it with his family and found a benefit from it. And so many patients that I've worked with have found that this was not only one that they felt, because a lot of times patients have used because of stress from finances. What if this happens? What if the car breaks down? What if I get laid off? Again, COVID things like, right, what if I get laid off? Or what if you had 3 to 6 months living expenses already in a thing? You don't have to worry about that. So now you can focus that energy on something else, like your families and communication and spirituality and whatever. So I get them and incorporate them into this. Because again, this is, I mean, the program that he has, it's budgeting, it's free, which is great. And I love the fact that it's something that they can do together. So if I have a husband that's in treatment with me, I'm going to say, hey man, I want you to take this home and you and your wife work on this. And I want you guys to see what you come up with. And so they'll come back in like in a day or two later and say, whoa, we're spending like so much money on groceries and then going out to eat afterwards. Like, what are we doing? And so like, you're like, oh, you guys just found common ground. Cool. Oh, so you guys are going to do this? Yeah, I think we're going to do this together. Oh, that's awesome. That's really cool. So now they're building this common ground. So I think that's such an important piece of it. And then one more thing that I think is really great is it's a company called the Skin Deep, but they have a game that they've on their website called The And. So if you just Google The And, you can check it out. They've got so many different editions that you can do. They've got dating edition, long-term couples edition, family edition, healing edition, children's edition, racism edition. I mean, they've got so many different wonderful things. And so what it is that it's a card. You pick out a card and you may ask, so for instance, for the healing edition, you may say, you may pull the card out and it's for you and your family to contribute, right? And everybody has to answer. And you may say, what's something you want us to get better at over the next year? And each party answers that question. Maybe it's the question of what can we do to help our relationship? And so again, family edition is, what do you like about me the best? Or maybe the family edition is what drives you crazy that I do. And so that it gives people this opportunity to communicate and talk with each other, because again, drugs and alcohol isolate us. So I think this is such an important piece of the puzzle. And so I wanted to make sure that I mentioned this. So it is time for our break. So I think we talked about maybe like 5 to 7 minutes. I believe it's 10:25, so maybe 10:32. Let's come back in. And then Lynn's gonna present her piece about the different types of approaches. So again, thank you guys so much. I'm gonna stop sharing my screen for a moment, and then again, we'll just be back at 10:32.
So let me do this. Is he talking yet? Is he said?
I think we're all still, I saw that in the chat, Linda and Loretta, I think we're all still muted a little bit. I was muted and I was looking at a coworker talking to him real quick. So it probably looked I was talking. My bad. So
Share Lynn's screen now.
Okay, we can hear them.
Okay, so you should be good to go.
Thank you.
Mhm.
So first thing I need to say to everyone is that I am not very sophisticated with the technology like Adam is. And so I have a wonderful extra person here named Sharon. And Sharon is here helping me with all things technological
I just realized.
and other
I
things.
wanna do one thing. I need to share sound. That's all I wanted to make sure.
Which one is it? I think it's that one. Wait. Yeah,
There we go.
okay.
Thank you.
Okay. Great. So do you want me to just start, Adam? Did you have anything you wanted to say before I start? You're all good? Okay, great. All right. So first of all, thank Adam. You know, did such a beautiful job of such an overview of why it's important to involve families and how we involve families. And I really appreciate also seeing the way he organized that information. So I'm sure that that was super helpful for all of you as well. What I will say is, you know, I realized in this process of putting this together with Adam that the piece that I am, I guess, most comfortable and most familiar with sharing and talking about is the actual family therapy piece. Like, how do we actually do the family programming? So I love that you kind of set that up, Adam, that family program is such an important piece of these programs, of any program really. And, you know, the truth is I'm still shocked when I see addiction treatment programs that don't have much of a family program. It's kind of surprising in this day and age. I've been in this field for almost 30 years. And when I started in the field, we did not have family programs. We had, you know, one day a week or one day a month where the family came and did a 1 hour group, and then they did activities and hung out with their loved one. And that was it. That was the entire family program. So I think that we have gotten a lot smarter and a lot more sophisticated about how to involve the family and why we need to involve the family. And I think it's, you know, nationwide, it's getting better and better. People are doing more and more of that. I will say, this is something I didn't say about Red Oak in the intro, that at Red Oak, I think that we have a very specific and sort of unique approach to the family work, in that every one of our families has their own therapist in our program. And so they are working specifically on themselves. They also come for a workshop, just like they do in the programs Adam was talking about. And in addition to that, we have family support calls where they're all on a Zoom together. And then we do calls with parents. We might do calls with siblings. We do calls with spouses, sometimes grandparents. So we're really involving the whole family. And there is someone who is just designated to work with the family. And obviously we do a lot of collaboration with what we call the primary therapist in our program. And the collaboration is key. If you're going to do really good family work and you have two different people doing it, you have to have some great collaboration. So I'll just say that to start with. So how do we approach family therapy and the family program? What I'll say is that our lofty goal, certainly my lofty goal always with families, is to take an approach that comes from a place of family systems theory, which is Bowenian family systems work, with a sort of attachment-based approach. So kind of couched in the whole sort of theory and organization of family systems methodology, but with a sort of specific, eye on some of the attachment issues, attachment wounds, attachment ruptures. I'll talk more about that in a minute. So that is the lofty goal. We would love to do that with every family that we treat. Obviously, we only have our clients somewhere in our program from 60 to 100 days, which is a certain amount. It's a fair amount of time to work with a family. The kind of family work that I would ideally be doing, which is to start to shift the system, which we call second order change. So in family work, we talk about first order change and second order change. And to do second order change, it's a very slow, long-term, gradual process. But we do have 60 to 100 days. And so we're able to do a fair amount of that work. And I have I guess my theory about it is that we have clients here, and in a sense, the client and the family is sort of a captive audience. And so we're going to do our best to do this kind of work with them because they are going to be here for a certain amount of time. And so we don't want to miss the opportunity, if there is an opportunity. Not every family is ready for that kind of deeper level work. For whatever reason, they have all kinds of barriers, mental health barriers, like Adam was talking about. Some of them have their own substance abuse issues. Sometimes there's, physical illness, or divorce is really getting in the way. So we still want to provide as much as we can to every family. So sometimes what we're doing is just emotion coaching, what we refer to as emotion coaching, which is helping them sort of build their emotional intelligence, so to speak, which is to be more in touch with what they feel at any given time, build their emotional vocabulary so that they can talk more specifically about what they're feeling, also begin to have some awareness of what they're feeling in the context of the relationship with their loved one. Because what we know is that those emotions are what is driving, for instance, the enabling behavior or the rescuing behavior. It's the loved one's internal emotions that are really causing that kind of behavior. So we want to help them understand that as much as possible and grow that part of their system as much as possible. At the very end, we do all of these things with every family, but sometimes people are just going to do some emotion coaching. And then sometimes we're just going to do parent coaching or even spouse coaching, depending on what the family configuration is. And what do we mean by that is really trying to do some psychoeducation around boundaries, enabling, addiction, codependency, providing them as much information as we possibly can, knowing that they are potentially not in a place emotionally or developmentally where they're ready to make some significant changes. At least we know at the end of the day that we have provided as much information and education as possible. We also, in our program, we have a family workbook that we put together. So we've pulled together various pieces of information that we try to give them. And then we recommend books and videos and podcasts and all kinds of things, just like any family program does, I'm sure. So now, are you going to advance or I'm advancing? Where do I advance?
Just try to click and see if it'll, there you go.
Okay, great. Yay. Oh, that's so simple. It's like magic to me. Okay. So what I'd like to ask everyone to do for just a moment is take a couple of moments and think about what we refer to as unmet needs. And this is attachment language. So all of us, just like Adam said, of course he's from a dysfunctional family. Of course, we're all from dysfunctional families. We all have some level of dysfunction in our families. I have not met that perfect family yet. I'm pretty sure they don't exist. And so we're on a continuum, and we also all have unique dysfunctions in our families. We're all very unique in the way that we have some dysfunction. So the question that we always pose to folks in the beginning is, what do I wish my parents had done more of or less of, or just different? What do I wish I had gotten different from my parents? And if you would just maybe jot a word or two in the chat box so that we can gather some of these responses. And now when I'm sharing, I can't get in the chat. Oh, it's up here, I see. Okay. Okay, so I'm gonna. I'm assuming everyone can see these. Listen more, actively listen, less overprotective, less violence, more affection, discipline, family talks, emotional availability, active listening, boundaries. These are great. Guidance, sobriety, less strict and less overprotective, more forgiving, how to say no. These are wonderful. Thanks you guys for answering the question and thinking about this. And what's always, I guess I don't know why I'm still surprised, but I'm always surprised when I do presentations and we do this moment of reflection that almost everyone has a sort of instantaneous response to the question. So what I believe that tells us is that we're all walking around with some woundedness or some sense of not having some of our needs met emotionally early on from our family of origin. And we carry those unmet needs and those wounds into our role as parents or spouses or partners or friends. We carry that with us, and it is part of the makeup of who we are. And I think the more that we understand what some of those places are within ourselves, the more we can become somewhat objective and pay attention and notice when those things are cropping up for us in relationships, because it is the piece that often creates some disharmony or conflict or difficulties in relationships, those places where we have not had our own needs met. Anything you want to say about that, Adam? Your thoughts? Do you want to share yours?
Well, listen, I thought I was just looking at the answers and I was really impressed with a lot of the answers. I think I put in there, practice what they preached. I think that was going to be a good one because there was a lot of inconsistencies.
Mm-hmm.
So, I think that statement we've all probably loved, right? Do as I say, not as I do. So those conflicting messages kind of sometimes send a confusing spot. But yeah, that was there's some really great answers in there.
Yeah, good. Thanks, Adam. And as I mentioned in the introduction, I'm the grandparent now of an 11-year-old, a 9-year-old, and a 1-year-old. And I've had more time with the 1-year-old because the older kids live internationally, so I don't get as much time with them when they were young. But watching the 1-year-old, you become reminded that they're watching and feeling and experiencing everything that's going on with mom and dad. And so it's not going to matter what mom and dad tell them is the truth or what to do, because they are watching everything and picking up on every single piece. It's really quite a renewed lesson in family therapy, watching them. So thank you all for answering that. And we also do that kind of work with the parents. When we're working with parents, we're trying to help them, again, drop into their emotional experience. We do have an activity we do with parents to help them go back into their family of origin and look at some of their unmet needs and begin to understand how that's impacting their family system, their current family system. So family systems theory, of course, was developed by a fellow named Murray Bowen. I mean, he's definitely considered the father of family therapy, family systems therapy. There are other types of family therapy and other approaches. But I think that you will find in almost any approach, there are folks are drawing from Bowenian work. So it's really helpful to have at least an overview of family systems theory. And the sort of illustration that we use always to try to explain to families why this is important. The question is why, why are you here? Why do we want to involve you? And the answer is that families are like mobiles, and that if you move one piece of the mobile, the whole mobile moves. And then if you let go of that one piece, it doesn't just go right back into place and stop and get back to what we call homeostasis. It actually takes a minute and everything keeps kind of shaking around and moving around. And so the metaphor is basically that everything that happens in the family affects everyone in the family. So everything in the family affects everyone in the family. And we're trying to help families understand this. Obviously, they are with us because their loved one has developed addiction their loved one also has mental health issues potentially. But more importantly, from a family therapy perspective, their loved one is a product of their family system. And we want to understand the family system that this client came from as much as possible so that we can help the family system shift and change and heal. And also so that we can understand some of the wounds and the dysfunctions that the client is carrying where it relates to the family. So yeah, so that's the mobile sort of metaphor that we use there. Parents tend to get it. This is a metaphor that works really well for most folks. I'm sure many of you have used the same thing in your work with families. Okay, so a second little activity is just take a moment and just think about, you can also answer this in the chat if you want, or you can not answer, whatever you want to do. Who is your family, basically? I mean, who do you consider your family? Sometimes we have families of choice. So we have our family of origin. We also have our intergenerational family. And then we have our nuclear family that we're living in right now. What are the roles in your family? There is, Claudia Black did a lot of work on family roles and addicted families, you know, the mascot, the hero, the scapegoat, and those family roles. But we all have roles in our family that may not fit it neatly into those 4 categories. For instance, I would say that in my family system, I am an accommodator, which means that I am going to probably defer to everyone else's decisions and opinions rather than create conflict. So I'm often an accommodator. And then how would you describe your relationships in your family is with your significant relationships? So something just to think about, and this is part of how we begin to assess the family system. We ask these questions of every family member who's involved and also the client who's in our program. And there are many more questions we ask to do a full assessment. What I like to say to families is that you have been in your family every day for however many years, whether it's 10 years or 20 years or 50 years. And I have been in your family and involved with your family for an hour or 2 hours. And so I'm going to need for you to paint a picture for me of the family system, which means I want to know everything that you think is important or relevant or potentially interesting, because there's no way to know which pieces are going to be helpful. So all of it is helpful. All of it's interesting. Many of you probably know genograms and have used genograms. Sometimes when we look at the intergenerational family system, we do genograms with folks. Sometimes I'll do a genogram as I'm talking to folks and assessing, but we don't necessarily do it with the family. But we're really trying to understand all those pieces, all the interpersonal relationships within the family, also understanding who is closest to whom in the family, you know, who is sort of on the outside, just many different configurations and pieces about the family system we're trying to understand. So I know some folks have responded. Thank you for that. I'm not going to take too much time to look at it right now, but yeah, parents are deceased, close friendships and acquaintances. Often we have these families that we've created. Mom, dad, sister. My role is the person who keeps everyone together in the household together. Yeah, I mean, when you start to think about what is my role in the family, and if you really look at how do I respond to situations in the family, and also maybe where are the places that cause me some stress or even resentments, you know? That's one of the ways to know what you're doing too much of is to pay attention to what you have resentments about. Because if I have a resentment about accommodating too many people in my family, that's going to give me a lot of information that I'm actually accommodating way too much. So rather than it being their problem, it's really something I want to look at in myself. Anything you want to share there, Adam?
No, this is like, and it really is such a great question, because again, I think, and a couple of people posted this, right, is that your family and your role in the family obviously changes as time goes on.
Yes.
But I did see one that was like really, really cool. Just, I think it was Jessica that posted in there, like, you know, one of the roles was to, you know, be the kind of the glue and keep everybody together, which is, it's a cool role to be in too, but it's also like, that's where one of those things, it's like, you see it and you go, well, wow, why am I the one having to do all this? Well, this is a lot of work, you know, and then but you realize that you need that person in the family to kind of hold things together. So it's cool to see the different roles and how we shift as time goes on, and as we go through our life. So that's awesome though. Great stuff.
Yeah, totally. I'll just share that, when my mother died about 10 years ago, and she really was sort of the central kind of, the vortex, whatever, center of the vortex in the family, the person who really organized events, and everyone sort of went back home. I'm from Mississippi, but we all live farther away. And she was the one that organized everyone coming back together for holidays and events. So when she died, that was empty. That role disappeared. And, and I think some of us tried to step in and fill that role, but actually the truth is no one ever really successfully created that role for any length of time. And so my family system changed as we lost one of our significant family members. And I think that happens in most families. I don't think that's too unique to my family. And it can be a sad, heartbreaking piece that happens, but helpful to understand that it's happening than to, just feel sad and not know why you feel sad. Okay. So I'm going to talk a little bit about family systems theory, and then I'm going to talk a little bit about attachment theory, because that's sort of the blend that we use when we're doing the deeper family work. So family systems theory, there are basically there are some key concepts that Bowen developed when he talked about family systems. And by the way, he developed his theory based on looking at his family and experiencing his family. So, just like all of us, he, had a lot of insight and awareness and got really curious about what he was experiencing and feeling. So key concepts, first of all, you have to think about the nuclear emotional system. So every family has an emotional system. So we have a logistical system, this person works, this person may stay at home with the kids, the kids go to school, or one of them is at home, and, one kid is the athlete, the other kid is more the musician or the artsy type or whatever. So we have those kind of roles in the family, but we also have an emotional system that's going on all the time. So when one person's anxious, it's affecting everyone else if someone is down or depressed. So we're always kind of intermingling, and there's all this interpersonal sort of interactive emotional piece going on. And we want to understand what the emotional system is of that particular family we're working with. Is it a family that tends to be overly emotional and they do a lot of emoting and a lot of sort of enmeshment and overdoing? Is it a family that has a lot of distance, or maybe even a lot of cutoff? What we call cutoff, which is where they've completely divorced the family in a sense. Or is it a family that has a lot of emotional distance? A very common configuration that I see is one parent, and I will say, not to be gender biased, but I will say more often than not, it's the mother who is a very emotional and expresses a lot of emotion and, sort of leads with emotion, as I say. And then the partner, often the dad, but it might be a female partner as well, the other person often doesn't lead emotionally. They sort of lead cognitively, and they are really trying to keep the emotions contained and limit the emotions. So there's a whole emotional system going on in every family. And you want to just get curious about that and understand by asking lots of questions about the relationships and the dynamics that go on. A key piece of family systems theory, this is probably, in my opinion, the most important piece when we're working with families, is differentiation. This is a very important concept that I'm finding myself, the longer I'm doing family work, the more I'm really delving into differentiation and trying to understand it more, and also trying to understand how to help people have greater differentiation. So the lack of differentiation is the thing that causes a problem with boundaries. So when we talk about boundaries, where the mom is rescuing the kid, where Julia Roberts says to the kid and Ben is back, for this 24 hours, you're mine, that is a beautiful expression of a lack of differentiation. I mean, she's coming from a place of, feeling trauma and sadness and heartbreak and discouragement, all those things that our families are feeling. But she has this approach that leads me to think that she still is living in the myth of, I can control this. That my emotional state in watching my son and loving my son is so so complex and so difficult, and I feel so sad and heartbroken, and I don't know how to manage my emotions. And so the way I'm going to manage these emotions I'm feeling is to try to control his every move. So the myth being, if I can control his every move, I won't have to feel the depth of these feelings that I'm feeling. And so that really gets into concepts around poor differentiation, where we would want to help this mom begin to differentiate more and more. Basically, we want to help her learn to manage her emotions herself as well as she can, so that she's not caught in this cycle of thinking the way to manage my emotions is to control this person that I can't control, or control this addiction that I can't control, right? So differentiation is super key piece in emotional and family systems work. Triangles is something that is natural and it happens all the time. Bowen would say that two people, there's insecurity and instability in a dyad and a two-person relationship. And so two people will often bring a third person in. You can see this in friendships. If you see, if you work in programs, you probably see a lot of drama and, sort of interpersonal conflicts that go on in our residential programs. And what you'll see is that two people have a disagreement or a conflict, and they're going to naturally turn to a third person to come in and say, well, what do you think about it? Don't you think that she's doing the wrong thing? Or he really, he shouldn't be doing that. Or, so they're going to bring a third person in. And what Bowen would say is that it eases some of the tension to bring the third person in. The problem, of course, where triangles can become problematic is when they become so exaggerated or fixed. And an example of a fixed triangle that is not functional. I'll give you this example of a family that I worked with where the mom had really poor differentiation. She had a lot of childhood trauma of her own. Dad tended to be more disconnected, distant, sort of the intellectual, the academician, a professor, really didn't want to get into the emotional piece too much. They have twin daughters. And so mom is over functioning and over emotional with the daughters, and as if she can control everything and make their lives perfect. And dad tries to get into that system, but he gets pushed out by mom because mom feels like he doesn't have enough to contribute. And so she has sort of eased the tension between her and her husband by focusing heavily on the children. And so the tension between her and her husband becomes greater and greater. And so what happens is that the kids, the twins, start to come to mom all the time for their needs, coming to mom always, 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 never going to dad. And so dad feels like he's been outsider, he's kind of been pushed out of the system. And so he, develops resentment. And then, there are those moments, what I've been able to observe in this family, in this particular family, is when things are really heightened and there's a crisis, the mom wants to pull dad in. Why aren't you here? Why aren't you helping? You need to be in this too. And as I'm watching, I'm thinking, you have spent so much time pushing him out, and now suddenly you want to pull him in, but it's probably not going to work very well because the triangle has already been set. And so they would have to do a pretty long-term work to shift that dynamic. So I hope that makes sense. But triangles are always happening. Sometimes they become very dysfunctional. Family projection is, to use the same family, the mother is projecting a lot of her unresolved trauma and anxiety onto the kids. And so she's hyper focused on the kids. Every little thing that goes on with them or every problem they have, she gets more anxious about, and she tries to fix and control and take care of. And basically what she's doing is projecting her own unresolved issues onto the kids. And you can see how over time, these twins, these kids, are going to develop various emotional mental health issues as a result of that, because there's too much because mom is not able to, hasn't yet resolved her own trauma and her own responses to her trauma. She's sort of visiting that on her children, as they say. I think the line is that the sins of the father will be visited upon the son, basically. And I take that to mean this is family projection. This is how it goes on intergenerationally. Again, back to Adam's point about the parents didn't cause the addiction. I think that that's always important to help people understand that addiction is a disease. And so while you may have, as a parent, created a system that has caused some emotional difficulties in your child, you didn't cause the addiction. And even the family dysfunction, if you want to find out who caused the family dysfunction, you're probably going to have to go back 3 or 4 generations at least to figure out where all of this started. So, and the whole issue of blame is not helpful. You know, one of the things that I will say to parents sometimes when they get caught in that blame question is, you know, I'll say, you know, no one's to blame here, but everyone is responsible. And so everyone wants to take responsibility for their piece, but no one's to blame. It's not like it's anyone's fault. And we're not looking to find fault. So sibling order, of course, most people know about sibling order and how that can matter. You know, the middle child being kind of the lost child a lot of times, or trying to be the peacemaker. The first child often being the family hero, being closer to the parents and more parentified. And then family roles again. And you can look at the Claudia Black's family roles, or you can just think about what your unique family role is in your family, or watch for those roles in the families you're working with. Okay, so attachment theory. And I know that I'm going through this pretty quickly, but you know, it looks like 3 hours is a long time, but it turns out it's not very long for covering a lot of material. Attachment theory, most of you are probably aware of it, so I'm not trying to tell people things they know already. I just want to make sure you see that this is incorporated into our family work. So John Bowlby is considered the father of attachment theory. Obviously, he was working with Mary Ainsworth and Mary Main, and they were also huge contributors, Mary Ainsworth, but he gets all the credit, but it was primarily his work. And the thing that I'm trained in and that we train our family therapists in is emotionally focused family therapy, which was created by Sue Johnson. And emotionally focused family therapy is an attachment-based focus on family therapy. And I highly recommend her latest book is really good. Her first book, I think, not very well written, but her latest book is really good. And our family therapists have all found it much more readable and helpful. And so the basic concept in attachment theory is this, that primary caregivers who are available and responsive to the child's needs allow the child to develop a sense of security. And that sense of security and feeling comfortable with who you are, feeling safe within your own skin, is the experience that allows you to develop health in a healthy way emotionally. And so all the places where that doesn't happen in families has an effect on children, and children will develop various kinds of responses. There's an important piece of attachment theory also. I don't think I have it on the slide, but I'll just mention that one of the things that they theorize happens in the process of the attachment relationship is what we call an internal working model. And so each one of us has what we would call an internal working model of who I am, how I am in the world, you know, where I fit in the world. And then we also have an internal working model of other, how I think about others, or others to be trusted. Can I call on people? Are people responsive to me? Can I trust that they will be there for me? And again, we see this show up in our clients and in our families. We talk about, rather than talking about attachment styles so much, we talk about attachment strategies. And so as we watch the family system and the family dynamics, we're seeing a lot of strategies that go on where everyone in the family is attempting to get their emotional needs met. And they have all kinds of strategies to do that. An example of that would be the child who is a pleaser. And we've all seen that, and maybe some of us are that person, where we just always want to please the other and give in to the other. It's a little like the accommodator, but even more so. And often the person who develops into a pleaser, where they, you know, the follower with their friends, the one who goes along with whatever's going on with friends, which is, by the way, a high trigger for relapse, right? Someone who's a pleaser and a follower. But that's an attachment strategy generally. It's that the way that I know to keep people close and to keep people there for me predictably is to do what they want me to do, or to go along with them. It's a predictable way of keeping people in my close orbit. Because as human beings, we are social creatures, we're social animals, and we want people to be connected to us and close to us. And we make all kinds of strategies to make sure that happens, or even to push people away when we don't feel safe. We have a lot of strategies that push people away also. Anything you want to add to that, Adam, about attachment?
No, I think it's awesome. Like I said, it's one of those things that, yeah, a lot of people know about, but maybe, don't think about it in the role of incorporating it as much as often. And so sometimes it's nice to go back through and look at some of those theories and pay attention to those and see how you can incorporate those into your practice and into the model. So, but it's, yeah, this is good stuff. I forgot about, that I forgot that Sue had wrote the first book, but yeah, second book, it'll be easier.
Yeah. And the most recent book, actually, they didn't even have a book on emotionally focused family therapy. When I trained in it 8-9 years ago, I had to go to Canada to train in it. Now you can find trainings in emotionally focused family therapy. And also there is a book finally. And I highly recommend looking into it, delving into it. This is a little illustration that speaks to attachment. It's from the Circle of Security, which is also a modality. But you can see where the secure base, basically, what's important is to have a secure base, a safe haven, have someone who's responsive to your emotional needs. And you see the kid here, I need you to support my exploration. So basically to let me explore, not to the point where I'm at risk or it's dangerous, but watch over me, delight in me, help me. I need you to welcome my coming to you. I think it's, is it Maya Angelou? I can't remember. I think it's Maya Angelou who had a statement about, we used to show this video to parents sometimes in the workshop where she says, make it be that when your child walks in the room, no matter how old they are, they could be 25, 30, when they walk in the room, your eyes light up, that they have the feeling of you're happy to see them, that it's a delight to see them. And you can imagine, and we all know how that gets corrupted when your child has addiction, because you're spending so much time feeling scared and frustrated and discouraged. It's really hard to light up when your child walks in the room and they've just stolen something or lied to you or gotten in trouble or had another DUI or wrecked a car or whatever has happened. There was a piece Adam was talking about earlier, I can't remember the exact place, but I think you were talking about and seeing how sort of Tim approaches families, and rather than, telling them what to do or being critical when you see some relapse behaviors, the phrase that kept coming up for me was, you want to preserve the relationship with your child. That's important, because if you don't have a relationship with your child, they're never going to come to you when they're struggling. And so one of the things that I say to parents too in our treatment program as they're winding down and finishing is, that you want to have a relationship with your adult child or adolescent child, whoever it is, that is such that you are at the top of their list of people they're going to call when they're struggling. You may not be their number one person, but you're going to be somewhere at the top of the list. I've worked with families who, I remember one family, a mother and a son, he had been addicted to heroin for 2 years and she had literally no idea. And they had a pretty close relationship and they saw each other a lot. The dad had died, so the dad wasn't involved, but she literally had zero idea that her son had any kind of thing going on, any kind of addiction, much less a serious heroin addiction. So, because he never told her, and part of the work that they did when they were with us is he was talking to her about all the reasons he didn't come to her and he didn't tell her, and that he couldn't trust that she could handle it emotionally. And he felt like he had to take care of her and protect her. And so the last thing he wanted to do was burden her with his difficulties. His mom was a very competent, strong woman. And so their work was about him beginning to understand more about what his mom could tolerate and what her capacity was, so that, she could be on his list the next time he was struggling with whatever it was. So anyway, Circle of Security, and there's a Circle of Security intervention, I think it's called, which is a methodology used with children, parents and younger children. Okay, so the thing that we're always assessing for, I want to watch the time. Are you watching the time? Let me know if I'm running too late, you guys. I can't see the time on my computer. We're looking at attachment ruptures, and there are all kinds of places where we have attachment ruptures. Obviously, addiction can create a lot of rupturing in a family, any kind of neglect. This is where we get into ACEs. I think one of the questions, the preliminary questions, was about ACEs. We actually assess ACEs on our initial biopsychosocial when our clients arrive to our program. So we're going through that, and then we're just really expanding that as we go along, looking at any kind of abuse. Parental conflict, divorce is definitely an attachment rupture, and it affects some kids more than others. So you want to really understand how much the child has been impacted by that. Rejection of the child based on sexual orientation, gender identity. Recently we did a presentation with a group where that is their primary focus, and was reminded of the high number of statistics of suicide and homelessness among young people who have been rejected completely by their family because of their gender identity or sexual orientation. So that's a huge, huge family rupture. Repetitive criticism, just someone who tends to, their go-to is criticism, even lecturing. I'm working with a young person right now and his family, and he talked about how his family they lecture, and, how it feels really oppressive and, just hard for him. It makes him really disconnect more and more and more from his parents. So rather than bringing them closer and helping them change what they're doing, it kind of creates distance. Enmeshment is also a rupture where there's too much enmeshment and too much overdoing, over-controlling, and then emotional distance. This is just a partial list. I mean, we can find all kinds of attachment ruptures. So you want to just really dissect the family and understand all the things that have happened. And sometimes there's an incident that has happened that no one even thinks is significant, that over time once you get to know the family really well and build a strong relationship, you hear all these different details, and you'll notice that there are some attachment ruptures that you wouldn't have naturally heard about. That has happened for me. Okay, so here's a clip we're going to show from Ordinary People, where I want to just illustrate a significant attachment rupture that's going on between the mother and the son here. This is an old movie. If you haven't seen it, I would say go back and watch it. We just need to cue it up here to the right place. Thank you, Sharon. Yep, there, right there.
It's cold out here. You should put that on, or do you want a sweater?
Do I need one?
What are you doing?
Nothing. Thinking.
About what?
Not about anything.
Your hair is starting to grow out. It's looking better.
I was thinking about the pigeon. You know, the one that used to hang around the garage? And how he used to get on top of your car and he'd take off when you pulled out of the driveway.
Oh, yeah, I remember. I remember how scared I used to get of that whoosh, flap, 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 every time I started the car.
Yeah, that was the closest we ever came to having a pet. You remember Buck asked you, he tried to talk you into getting a dog? Do you remember that? And he said, how about if it's just the size of a little football?
You know, that animal next door, that Pepper or Pippin, whatever his name is.
Pippin.
He's not a very friendly dog. I don't care what Mr. McGreary says.
What he really
He's
wanted
really
was the
not.
retriever that was down the street for
And
sale.
every time
That's
that
what he
dog
wanted,
comes
the
into this
retriever.
backyard and I try to get him out, he...
Arf! Arf! Arf!
Put that on if you're going to stay out here, okay?
Can I help?
Help what? Oh, you mean with this?
Yeah.
No.
I will.
No, I'll tell you what you can do, though. You can go upstairs to that room of yours and clean out the closet.
Mom?
Okay? Because it really is a mess.
Conrad, where are you?
Okay, so I'm turning it off. How do I get back? All right.
Is that what you want?
I think so, yeah. Okay, so if you haven't seen Ordinary People, I'll just walk you through that a little bit. The backstory, the context is that his older brother has died in a sailing accident, and he was there with the brother. And so he's had significant trauma, emotional response to it. A lot of different things. I won't spoil it by telling you all the pieces that have happened to him. But obviously they're all in this deep grief state about the loss of the older son. And mom, you can see, is really kind of wrapped up really tight emotionally. It's very hard for her to be present emotionally. And her grief has caused her to go even more sort of distant emotionally, so to speak. And the son is suffering, of course, and suffering even more because the mom is not able to be present emotionally. But this scene is a moment where this is the language we use in attachment work, where the mom comes out and makes a reach. And we talk about people making a reach for connection. So the mom comes out and makes this beautiful reach to him. But, you know, there's been so much distance and so much wounding between them that he's not able to respond or accept the reach. And instead, he pushes her away by the way that he reacts. And she doesn't know how to handle that emotionally. And so she leaves and goes back in the house and gets focused on a task. And then the other really wonderful piece of this clip that I love is where he comes inside and then he makes a reach. It's clear that he realizes his mom was making a reach to him after the fact. And so he gets it. And he comes in the house and tries to make a reach to her. I will help. Can I help? And she says, no, but you can go clean your room because it's a mess. So again, it doesn't land. And this is such a small like moment in this family. And you can imagine there are many moments like that throughout the day, throughout the week, throughout the month. And a lot of our families are having some of the same experiences where they may be reaching, they may want to really connect and be more open emotionally, but they're so wounded, they're having a hard time doing that. So one of the things that we try to do is help parents. We help the client begin to, obviously they're doing a lot of healing of their own around their addiction and their mental health issues. We're helping parents understand all of this. And then we want ultimately to bring them together so that they can talk about the places where there have been desires or reaches that haven't been met. And so there's been wounding. And basically the parents have an opportunity to make repair to the child. So in facilitating repair, basically we use the EFFT modality. I won't go too deep into that, but it's, you know, parents say, how do you repair? And I say, you know, apologize. It's kind of a one-word answer, but that apology needs to be sincere and, you know, heartfelt. And we want to help parents get to the place where they really do feel that. We don't want them apologizing just for the sake of saying it. It's not gonna heal the wound if it's not authentic. And that's okay if parents aren't ready to do that. That's okay too. Try not to be judgmental of where the parents are at. And then just evaluating the family system and the child evaluation, treatment of the child, even if the child is 35 years old. And then we do interactive phone sessions that are aimed at delineating these attachment wounds. So we listen and observe and hear the client and their family talk and hear both sides of the story so that we begin to know as clinician what some of those wounds are so that we can begin to help them know where some of the wounds are that they might want to work at repairing, whether it's divorce or criticism or just emotional distance, whatever it is. And then we do a sort of a longer interactive family session that we call a family intensive, where the parents or the siblings or the spouses and, you know, come together with the loved one and they do this significant conversation that's very vulnerable and emotionally and focused, and they do a lot of repair of these emotional wounds. And then the last piece that we do with our families is we have them write something called a letter from the heart, where they share with their loved one their story of their family of origin and what some of their woundedness was and how it has informed the way that they're showing up in the relationship with that person. So they're really beginning to look at themselves and their own work. Do you want to add something, Adam, here?
Yeah, I was just gonna say too, like, what you mentioned about the interactive phone sessions. And one of the things that's helpful in that process is because we built both relationships with, the family, but also the client. Because we're not emotionally attached to that situation, it's easier for us to pick out and see the reach.
Yes.
And so when they ignore it, we go, well, hold on a second. No, they were kind of extending something. So like, let's go into that. And so instead of them having to have this separation when they're off the phone and go, oh gosh, I didn't realize that's what they were doing. In that moment, kind of helping them and kind of retraining them to look for that, to look for the reach in that moment. To truly be, present and listening to what they're saying instead of processing the conversation later. And so it takes some time, but it does help them with finding out, and acknowledging, well, no, this person's they're trying to reach out to you on this. Like, let's go with this. So
It's beautifully said. I mean, that is exactly what the role of the facilitator is to be that fly on the wall, the person who can see what's going on there and help people begin to see it themselves, because we can't see it because we get into these defensive postures and we can't really see what we're doing. So yeah, it's really beautiful work when we're able to get families to the place where they can do this kind of repair. And again, I would say in our families, it maybe happens in about 70% of our families. So there is always going to be, other families that are not ready or not able to do this work for whatever reason. And so some helpful readings I added here are Attachment Focused Parenting, which is Daniel Hughes. Daniel Hughes is an attachment expert also who does a lot of attachment repair work with families, particularly with adopted children. So he works with a lot of folks, has over the years. I assume he's still working with folks with like reactive attachment disorder, more significant attachment wounding. And then The Real Dope on Dealing with an Addict is another little book that I think it's written by a couple of folks who are not clinicians. They just are writing about their family experience, but they're really talking about their codependency and enabling and how that's part of the addiction. It's not, it's not on the sideline of the addiction. It actually is part and parcel of the addiction. And then The Lost Years, I think, is a great book for families because it is written from the perspective of the mother and the daughter in her addiction moving toward recovery, and the mother in her recovery and her codependency and recovery from codependency. And each chapter, it's like daughter writes one chapter, mom writes the next chapter, daughter, mother. So the whole book is written that way. So it's really helpful for parents to see that process. And then the last book that we recommend for almost all of our families is The Parallel Process, which it really just focuses on attunement and presence, how to be present in relationships and attuned to the other person. And it's also a nice, short, small book. So I love finding books that are kind of short and sweet because I know people are busy and, they're exhausted and they have a lot of trauma and fatigue of their own. So I'm not trying to overwhelm them with a lot of reading.
Hey, Lynn, one of Alice just posted a question. If you could explain what the letter from the heart is again.
Yes. Yes, great question. So the letter from the heart, and I'm just going to say, my son went to wilderness therapy when he was a late teenager, and I stole it from them. I'm just going to give them credit. They're not open anymore, that particular program, but it was such a healing experience for us that I just said, well, I'm going to keep doing this. So we've shifted it and changed it and edited it a little bit, but basically there is an assignment sent to the parents or spouse or whomever that is, and they have prompts. It's like, we're writing this letter to aid in the healing of the relationship between you and your loved one. And what we want you to kind of share with your loved one is your experience, from an attachment perspective. And so there are some prompts on the letter, on the assignment. And the prompts are, what was your relationship like with your mother, with your father? What were some things that you wanted from them that you didn't get? What were some of your unmet needs? What were some resentments that you have toward your family of origin? And then there may be a couple of other questions I'm not thinking of. And then there are a couple of questions about what are some of your regrets in your relationship with this particular loved one, particularly parent to child? What do you wish you had done more of or less of or differently with your child? And the parents, basically, it just prompts them to write this very open-hearted emotional letter about their whole emotional experience as a parent and where that came from. And then they send it to their loved one. And we have the loved one in our residential program read it with their group. And so the group, while they have heard all of the difficult parts of their relationship with the family all along, here's this moment where the group gets to see also the love and the potential for repair that's going on in that family. And particularly with clients who are new in the program, seeing this for someone who's been there for 70, 80 days and they're doing the letter from the heart, super hopeful and creates a lot of optimism about healing in their own family. And I will see about getting you a copy of the questionnaire. I'll maybe get it to you, Megan, and then you can share it, or Sherry. But yes, we definitely, I'm willing to share it, definitely. I took it from someone else and I'm happy to share it with anyone who wants it. Share the love.
Thank you both, Lynn and Adam, for the great information that you shared and the resources, and just overall great presentation. We have had a few questions that I've kind of been monitoring, both through the chat and the Q&A portion. Plus, we also had some questions when people actually registered that they had submitted. So I want to kind of go over a couple of those in the last 30 minutes that we have remaining. So I'm going to ask both of y'all questions. Feel free, one of y'all answer, pop in, however y'all want to do it, if you have anything extra to add. This one's for Adam. What are the greatest challenges for clinicians that are working with the substance abuse population? I know this is a very difficult population, can be kind of stressful and draining and exhausting at times. So what are some of the biggest challenges that clinicians have?
I think I probably should unmute. That'd probably be a good idea. I think it's not getting so attached on one outcome. So if somebody goes and comes in and you get connected to that person, and a lot of times it happens early in your career. I know it did for me. I'd get attached to somebody and I'd really want them to, really root for them and really wanted them to get clean and sober and do something. And either they relapsed or unfortunately they went back out and they didn't make it back in. So then I started challenging and questioning, like, gosh, am I even a good clinician? Am I even good at this? And so I think that that's part of it is learning to not have that, I guess, not lose that empathy. So I think part of those things that can really help, one is being surrounded by a really good team. So I know that in Birmingham, like, I'm super fortunate to have, like, we have such a fun time here. We make each other laugh and we cut up with each other during the day, but then also, like, we talk to each other at night, even after we leave work sometimes, just because we have such a great rapport. So we can help each other and kind of, when one of us is struggling, we can kind of pull each other up. The other thing, though, I think it's important, though, is to take is practice self-care. That's really important. Because, and that's where boundaries come in, because self-care is something that can be, I think I looked at it from last year. I think I had like over 200 hours that just went bye-bye, that I had accumulated, but I literally love what I do. Like, I'm just like, I don't want to miss work. Even when I'm on vacation, I don't want to like leave. I just love what I do. But so I think that's going to be that's really important, is to have a good set of boundaries for yourself, is to realize that, listen, we're there to plant and be helpful to patients. We're there to plant a seed. Sometimes the seed grows right then and there when they're there in treatment, and sometimes it may grow later. And it has a ripple effect. We can't always see the outcome of what that's going to be like, but I have to remember that I have so many other patients and clients on my roster that I don't want to neglect those people too. So if I have maybe a down day with one, it's like, but I've got 9 more or 10 more or whatever, that many more to like that I can have a positive impact. So, but I hope that answers the question for you guys.
Lynn, did you have anything else to add to that?
I think maybe Adam didn't say this, but the one piece I would say for clinicians with family work is remembering to not take it personally when families are upset or families will lash out. You know, they're lashing out to the person who's in front of them because they're suffering. And it can be really hard and really intimidating and kind of overwhelming for newer family therapists for sure. I would say over time, all of our family therapists get really good at remembering that this person is suffering and that is coming from a place of suffering, and that, you know, you just can't take it personally. So I think that's one of the hard pieces. Otherwise, I completely agree with everything that Adam said. You know, all those pieces are the things that are hard for folks. And self-care, and you know, it turns out that therapists who work on self-care with clients all day long are sometimes the worst at self-care. Just turns out we're not really that great at it, you know.
Yep.
Okay, this one's for Lynn. How does a person know when they are financially helping or continuing to enable a person's substance use?
I actually saw this question because you shared it with us earlier, Sherry, I think, and I thought, oh, I love this question. Number one, I think it's a really hard question, and there probably isn't a real clear, you know, black, white-ish, you know, answer to it. But here's what I kind of coach parents to do. And, you know, this is the piece where I come from this place. So every situation is different. But what I say, and often I'm working with parents who have young adults, they're 18, 20, 22, something like that. So they're still launching. These are young people who are still launching, and they still need their parents' assistance for a lot of financial things. And what I say is, if your child has been completely cooperative with treatment and has, you know, done whatever aftercare is recommended, and they are working their program of recovery, they're going to their meetings, they have a sponsor, whatever their plan is, their treatment plan, if you see them working really hard to be positive and stick with the plan, and then they decide that, you know, they are going to buy a car, but they want to know if you can contribute to that financially, or they want you to help pay for insurance. I say that is strictly a family financial decision. When you are helping your child who is healthy and working really hard to maintain their health, I think you're just, you know, that's being a good parent. That's not enabling. If your child is caught up in their addiction and it's clear that they're very unhealthy and they're still in that cycle, almost any financial contribution is probably a bad idea, because it's probably going to at least indirectly support their addiction, if not directly. So, you know, you might think, well, I'm buying them groceries because they need to eat. These are the kinds of things parents say. You know, they got to have food, so I'm buying them groceries. Right. So now what you've done is you freed up that $75 or whatever so that they can spend that on drugs. And you know that they're still using and still very unhealthy. And so why would you want to contribute to that? What you really want to do is contribute to your kids being healthy and alive, right? So that's the marker for me, is really what's going on with that person that I want to give financial assistance to. Do you agree with that, Adam, or can you add something to that?
Yeah, for sure. No, that's yeah, 100%. I agree with that. You know, we kind of make kind of the clear distinctions. I think sometimes when we, especially in the family program, we've talked about it before, is that we draw, you know, enabling is doing for someone what they could or should be doing for themselves, and helping is doing for somebody what they are unable to do for themselves yet. And so I think that kind of helps maybe make the clear distinction of, you know, I'm not going to pay your bills when you're capable of paying your bills, you know. And again, like, and especially if you're just mismanaging your money, or whatever, I'm not going to go without just because you chose to be irresponsible. And so, and again, going back to the idea of money, and it's like, well, listen, I mean, you can go, you know, groceries, it's like, you can go 30 days without eating. You're fine. You're fine. Just drink water. You're good. But again, that's where I want to make those clear distinctions, and I want to set those boundaries up, right? Which is that, like, hey, I'm willing to help you, and here's what you need to do. Here's how you need to, you know, participate on your part. And here's what I'm willing to contribute. And again, like what Lynn said, if somebody's participating in their recovery and really doing a great job with that and really putting in that time and effort, then I'm going to help them, but I'm also going to set up a timetable, because again, I'm not going to do this forever. They have to understand, hey, there's a 3-month window or a 6-month window that I'm willing to help you. And so this is what, so I need you to understand. So when you get to the 3-month spot, don't look surprised, because you're agreeing to this, so don't, it's about, and a part of that is the communication piece of it, but each family needs to have that conversation with each other. It doesn't need to be one or the other, the mom or the dad or the spouse. They needs to be like a team effort. So everybody's on the same page.
Okay, this one's for Lynn. What are adverse childhood experiences and how do they play a role in working with the substance abuse population?
So that's a really big question. So there was a study done back 20 years ago or so by Kaiser Permanente in California, where they looked at all of the sort of childhood experiences that were contributing to physical illness and mental illness and addiction. And so all the various kinds of experiences kids can go through that have a high correlation with developing those kinds of difficulties. And it's basically a 10-question questionnaire on, have you witnessed physical violence in your home? Have you been the victim of sexual assault or sexual abuse? Have you been heavily criticized by your family? Have you felt neglected? Have you felt that they were not emotionally available to you? Have you experienced divorce? And so many of us, I am someone who is divorced. My child went through divorce. So essentially the study showed that if you have one yes to those questions, you have I can't remember the exact numbers, but it's like 30-40% greater risk of developing addiction, mental health issues, or physical health issues. And so if you have 2, obviously it's going to keep going up exponentially. And, I've worked with I've done presentations at some schools in different school, situations where I remember one in particular with a whole school board, that was the whole county school board was involved. And we had all the teachers filled out the ACEs. We gave them a copy of it and they filled it out. And we were talking about this and saying, you're probably seeing kids who've had at least 1, if not 2 of these. And several teachers raised their hands and said, what if you can check all 10 of them for several of the kids in your class? And, so basically what you're dealing with is some significantly traumatized children in your class. And you're a teacher, not a mental health professional, but that's what the ACEs is. It stands for Adverse Childhood Experiences Study. And it was done by Kaiser Permanente. It's lots of information available online about it. So recommend you look it up and check it out.
We've had a couple of different questions come in regarding family addiction, on the impact on children and adolescents. Is there any advice that you have for parents or maybe clinicians who are working with children or adolescents, or maybe some books or materials that could provide insight to help explain addiction to children or adolescents when working with clients who are addicted?
I don't have great ones. Adam, do you have some good suggestions on that?
One that I think is helpful is I mentioned Al-Anon, being for family members, but there also is Al-Anon has a branch off called Alateen. And so where it's other adolescents can kind of get together and gain some insight and some feedback about how that happens, and really kind of talk about like what's going on with them, so that they have a safe place. But also, again, getting kids into, an individual counselor is obviously going to be a really helpful thing for them as well. So they have a safe place to share, so that they have a place where they can say whatever it is they need to say without having judgment or having consequences or repercussions. Casey put in there Recovering My Kid by Joseph Lee. So that's obviously a really good resource as well. Even for our family program, one of the things that if the kid's 13 or above, they can come into the family program. So again, we want them around that age, simply because again, some of the conversations are going to be a little bit more, in depth and adult adult, mature oriented. So we want them in there, but we've definitely had, especially in the summertime, we've had adolescents that came in there and really learned a lot about it. And I think it helped them a lot to understand that, mom and dad or whomever it may be that's a part of the family that has this is not doing this. It's not like what we said earlier. It's not personal. I know that I was that way with my family. I've shared this before, is that, when it came to drinking and using, because I really truly thought I was going to die. Like if I didn't use, I thought I was going to die from the withdrawals, that I was going to go over you, under you, around you. And if you were in my way and it didn't matter who you were, I was going to go through you. And for kids, it's really challenging because they're just like, well, gosh, does my dad or my mom not love me, or does my sibling not love me, or whomever it may be. And that's one of the things that we get to do, is we get to say, hey, listen, man, that has nothing to do with that, and don't worry, like, they do love you, like they, and we can kind of give them that reassurance, and try to help explain it, because it is a challenging thing. It's a complex topic. And kids don't always have, especially the mental capacity to understand that. And some do, but some don't. So we try to meet the family and the kids, where they're at. I think that's important to do that. So.
Lynn, this one's for you. How do you help a partner resolve the anger and resentment to bring the family back together?
Well, that's a hard question. Let's see if I can have a short answer to that. So, I mean, I guess step number one with all family work is that what I think is really important, and what I, sort of train our family therapists is, you have to be all in with that family member. You have to, build a really solid relationship with that person, and you have to find your way to having deep empathy and compassion for whatever their story and whatever they're presenting. Because if I go into the family work with a partner who's angry, and I'm triggered personally by the fact that they're angry and they're presenting that way, I'm not going to be able to have enough compassion for that person to help them start to look inside and really look at their feelings and look at their anger. And so number one, just finding that place of deep compassion. And that's a place where I too have gone for supervision, because we all are triggered by certain kinds of clients. And sometimes, someone who's really angry and constantly critical or kind of lashing out can be really hard for me, probably for most people to work with. But I'm always trying to go underneath that behavior. What I always say is that we're not working on behaviors. We're not really a behavioral program in that sense. We're really trying to go deeper to understand what's the motivation. Why is this person angry? Why are they critical? Why are they lashing out? And then I want to really be present emotionally with that person's woundedness. And the better I do that, and the more that person's willing to show up and be in conversation with me, and I can do that with them, the more that I can soften their feelings. We talk about it as softening. And one of the first steps in emotionally focused therapy is sort of, suddenly I can't think of what you call it, but it's calming down the conflict. It's like really, trying to calm down all of that heavy emotion that's going on. And there are some specific techniques and approaches that you use, but the primary piece is just to be present with them emotionally, to help them go to the vulnerable place. Because when people can go to their own vulnerable place, they can soften those emotions. So that's a hard question. It's hard work, but it definitely is possible with most people, not all people.
Tell them to go to a rage room.
That's a good one.
Yeah, and I know in Huntsville has it. In Huntsville, you go to you sign a waiver or whatever. You put on some gloves, goggles, safety gear, or whatever, and it's this room that you can just smash stuff.
I love it.
And it really is fun too. I mean, because you can put on some music and stuff like that. But and then that's kind of a funny answer, but it is sometimes people need to get that feeling out, or exercise. I mean, they really need to kind of get back engaged.
Mm-hmm.
I think a lot of times they are upset and frustrated because they've had to put a lot of their stuff on hold, their life on hold. And we're trying to encourage them to get back into those things, get back into those hobbies, get back into your activities.
Mm-hmm.
And even on Zoom, I mean, I do this with patients on Zoom sometimes. It's like we'll we'll do a 10-minute mindful meditation. And so I may not even start, especially even with family sometimes, I may not even start the session with them because they're so ramped up. And I'm like, hey, let's do a 5-minute meditation really quick. And let's start this, and I'll just say, hey, this is what I do with everybody or whatever. But it at least kind of gets them a chance to be more present in the moment. And then I can say, okay, well, how do you feel now? And they're like, oh, wow, I really feel really good. Okay. Like, or I'm feeling better. I'm feeling, okay, let's talk about like what's going on. And so then we can kind of, I don't know. I mean, like because it is frustrating, right? And I get it from the family standpoint. One thing I'll pose to people though a lot is I'll ask the question, are you resentful at the person or is it the behavior? Because there's a difference. Very rarely am I ever resentful just at a human being, right? But most of the time I'm resentful at the behavior. So if I can learn to separate those two things, then it's like, okay, now I can start working on it. Okay, well, let's talk about what this behavior is and let's talk about how this behavior affects you. And so now we can take it away from the person and individualize it to to the family member. And they can start working through it and processing it. And then I can say, hey, this would be a great way for you to like, let's get you plugged in with a great family therapist. And so you can start working on this while they're in treatment, or, hey, let's look at some of the resources that we have available, that we have, family support groups. I think Ann put that in the chat, and like and especially during Zoom, in beginning of COVID, we started a Zoom family support group that we do every single week, right? And it gave families a chance to come in and meet with a licensed therapist. There was one where like, other family members may have their loved one while they're in treatment being there. They may have somebody who's already gotten out of treatment. They may not even have somebody that's in Bradford or Red Oak, right? It's just an opportunity for them to jump in and say, hey, I'm kind of curious about the treatment process. What does that look like? Or what should I expect when my loved one gets out of treatment? And so they can just kind of ask from a more, general standpoint. So there's definitely a lot of great resources that are out there to work with families.
Kind of piggybacking off of that, one of the questions we got in the question answer box was regarding that intervention process with a family member, how to encourage the loved one that they have a problem, need to seek that treatment. What are some intervention strategies? And this is for both of y'all because it may be different, for Bradford versus Red Oak, but what are some things that you would advise a family member if they were in the situation of trying to motivate that family member to get treatment? What are some things that they could do with that loved one to try to motivate them for treatment?
I mean, it depends. It depends on, I guess, the nature of the relationship. If it's like my son or daughter, or my spouse, right? I mean, there's certain things that I could do. I mean, I could potentially start making the world a little smaller for them and saying, hey, I'm not going to pay for your cell phone and contribute to this behavior. I'm not going to, you're no longer able to come to the house. And set kind of those boundaries. I'm not going to stay in this relationship if this is the way that this continues. But I'm also, there's a great TED talk that's out there, and I can't remember the guy's name, but it's called "Everything We Know About Addiction Is Wrong." And it's such a powerful statement because what he says is in the end of it, it's one of my favorite quotes from the whole thing. He says, this whole time we've been singing war songs to these addicts and alcoholics, right? Put the ultimatum on and do this or kind of control them. He said, but what we should have been singing was love songs to them because that's what they needed, And I think about that a lot with patients and I think about like, if it was me in that role, yes, Johan Hari, yes, thank you. I think back to in what way would I want to respond? In what way would I want my family to talk to me? And so like we can kind of bring that into the thing. So again, I want to set some boundaries and I want to say, hey, like I can let you contribute. I can't financially contribute to this, but I love you and I'll take you to treatment at the drop of a hat. Like I will stop whatever I'm doing, like to help you. And this is what help looks like for me. This is what I'm willing to do to help you. So I'm not abandoning you. I'm not neglecting you. I'm not pushing you to the side. I'm just saying like, I can't be part of you. I can't contribute to part of your addiction. But if you want to go to treatment, if you want to go to help, if you want to go to a meeting and you want me to go with you, I will go with you. I will meet you there. I will jump on a Zoom meeting with you. And so it's such a powerful statement to like just let these people know, because again, these are some wonderful human beings. Like these are some of the most loving, caring, kind, compassionate human beings when they're clean and sober. When they're using, they're different, you know. And so I just have to remind myself of how to, you know, to interact with them. And then also too, in the big book of Alcoholics Anonymous, they've got a whole chapter called Two Wives and the Family Afterward. And that's really powerful because I can kind of tell you what to look for in looking at that kind of stuff. So what about you, Lynn? What do you think?
I think it's a really tough one. I agree. I think, you know, what we talk to parents always about leverage, you know, whatever leverage you have. And I think the relationship is the primary leverage anyone has. So really just to completely agree with you, Adam, on that again, if we can help that parent show up relationally with that loved one, to help them know that they are loved and that they're safe and supportive, but they're not going to indulge and enable this unhealthy behavior, you know, because why would we? What I say is, like, it's not very loving to contribute to your loved one's potential death. I mean, it really isn't very loving. It comes from a place of love. It initiates from a place of love, but it's not a very loving action, actually. And, you know, I can be very direct with parents and say things like that can be hard to hear. But I also think we know addiction is a potentially fatal disease. So, you know, why wouldn't we be really direct and, you know, a little bit heavy-handed with that? But definitely just using whatever leverage they have, whether it's financial, relational, you know, living situation, whatever it might be for that person. And I'll say, you know, with Red Oak, because we treat adolescents and young adults, our admissions team, they do an incredible job. I'm sure it's the same at Bradford, where they might spend 3 months on the phone with a family, coaching them and helping them get to the place where they can actually finally, you know, bring them to treatment, sign on the dotted line and do that. And, you know, also just using the intervention approach of just helping, like Adam said, making their world smaller and smaller. So coaching someone to do that. And that can take, I've worked with families in outpatient where it can take them a year to get to the place where they are emotionally ready to do that. So you have to be patient with people too. They're not always ready to do it when you think they should.
Yeah, just to kind of piggyback off what you said, Lynn, I was thinking that with our admissions team too. Sometimes, you know, having our family members try to listen to us doesn't work that well. So we have a really great admissions team at Bradford and Red Oak as well that will really work with that patient and really try to motivate them for a treatment that they will actually buy into. If we can't, and if we're not appropriate for them, then we will find treatment for them that they are appropriate for. But it just kind of gives that added leverage to the family to help motivate the patients and talk to them. I know Lynn, if you want to share yours, I know our admissions number for Bradford is 1-888-SOBER-40. Very easy to remember. So if you do have a loved one or know of somebody who wants treatment, then they can call that number and they'll speak with one of our admissions specialists.
I'm going to put our number in the chat, you guys.
Fabulous. What kind of, as far as both the programs for Bradford and Red Oak, is there a particular curriculum that you use for family and substance abuse treatment? I know we've mentioned a lot about the broken brain. With Bradford's family program, it's gone virtual. So I know we've had a lot of back and forth in the chat box about it. I put the link in there as well. Tim Hilton does facilitate our family program. It is opened up to anyone. It doesn't necessarily have to be a patient of Bradford. Anybody can register for it and attend it. It is a 2-day session. He does cover the broken brain as part of his discussions in there, but he covers so many other topics. It's not actually titled the broken brain. Adam has done, when the pandemic first started, and we shifted to virtual webinars and CEUs and stuff, Adam actually did the broken brain presentation for us. And because we've had so much talk about it today, hopefully we can talk him into doing another one for us here in the next couple of months. So that way we can get it recorded and out to all of y'all. But as far as the family program specifically, is there like an evidence-based curriculum that they kind of use with the families at either program?
We've kind of created our own. So no, that's a really hard thing to find. And I think there are a few out there that, we probably incorporate. We incorporate various kinds of, family modalities.
Yeah.
We even use Love and Logic some with our, we teach them some of the Love and Logic pieces that we think are helpful. So it really is a blend for us.
Yeah, and I think for us too as well. I mean, because we're, and it changes so often. And the dynamics of the group is going to change so often. And again, learning how to shift it from virtual and stuff. But I mean, there's definitely some stuff in there, CBT stuff as well that can kind of come up in there. But there's just, little sprinkles of things in there throughout. And again, it's just mainly getting them the resource that they need.
And we have time for one more question. I'm going to follow up with this. I did see where we had just got a question in about utilizing DBT skills. We do actually, as part of Bradford, utilize DBT, motivational interviewing, CBT. Lynn, do y'all use all of those as well at Red Oak?
Yes.
Okay.
At both of our young adult programs, we have someone who is trained in DBT and does DBT groups. And so, yeah, definitely.
Okay. The last question I'm going to end with, and it's kind of several parts, but this female says, I'm working with a teen who lives with extended family due to ongoing addiction issues from parent. Lots of trauma, and parent continue to be reactive with client and exacerbate her emotional or mental distress. What kind of boundaries can be set, and when do I know if or when to encourage the teen or family to cut off contact? So I guess kind of working with resistant family members, and how do you kind of work with them and then know when to actually, that it's no longer productive working with them?
I think you've got to use kind of your gut feeling on that. I think as the extended family, I think there's got to be some stuff, and say, hey, this is what needs to be done in order for this relationship to at least, hey, we want this relationship to continue, but we don't want to energize this deal. I would probably be getting the teen into counseling so they can talk about it and process it. And then I may even look at, encouraging them to, like, if they do have contact, to, hey, let's just do FaceTime like once a week or something. So that way you kind of know what to expect. And so that the teen can do that. I know that I had to do that as an adult, though. I had to do that with a parent, and set that kind of boundary, because I didn't want to, because it was reacting. It was very reactive for me to have to deal with kind of that experience. And I had to set a hard boundary. And unfortunately, that was the last boundary I was able to set with my dad before he passed. We never had contact again. But I did know that it was important for me to do that. And I think a lot of families don't want to take that person away from their loved one, and they're not. That mother or father will always have the title of mother and father. They'll always have that title, but they got to show up and they got to be present for that child, ultimately. And that child's safety is going to be my first priority. So getting them into therapy to talk about it, to process it, have a safe place, and then set some boundaries with the parent and say, hey, if you want to have this conversation with your child, these are some things that you need to do, and not just once, but we need to have some consistency, and so that they know specifically what they're looking for. So the moment that this person's not being consistent, I kind of know, hey, to prepare myself that, hey, this is, and then I can have a conversation with the kid. So if it's a teen, though, they're probably going to pick up on it pretty quickly. But that's a great question.
Yeah, and the only thing I would add is I actually was in peer supervision with someone who had a very similar situation, I think. And the child was living with the the grandparents, I guess, the grandparents. And it was the biological mother who was addicted and living separately, but still very involved and constantly kind of stirring things up and creating some more emotional distress and trauma for the child. And the people she was living with, the grandparents she was living with, were not, they were very reluctant to draw boundaries and hold boundaries with the mother. And we're having a lot of trouble with that. And so the clinician I was working with had worked with them for a long time, stayed with them, very patient, sticking with them, teaching them how to hold the boundary and how to keep the child safe. And eventually they just were not doing it. They were too caught up in their own enabling. And so we together decided that the best next step was to report it to DSS because the child was being harmed emotionally, not physically necessarily, but there was always sort of a risk there. And what was interesting is that when DSS got involved, they also got one of the community mental health folks involved. And they, the family was a little more responsive to that sort of more heavy-handed. And they didn't fire the therapist. We thought, well, they may just fire you. And so that's okay, but you've still done your due diligence and done what you can. But they didn't, but it actually motivated them a little bit more than just the therapist working with them. So, you don't want to do that unless you have to, but you definitely want to do it if you need to.
All right, well, thank you so much. This concludes today's session. Please remember to be on the lookout for a post-session email that you should receive. It will have materials from today's presentation, including the PowerPoint slides and a link to the recording of today's session in case, I know we shared a lot of material, a lot of resources and stuff, so you will be able to listen back to that. There will also be a link to to complete the evaluation for the presentation today. So make sure you complete that. Give us about a week to 2 weeks after you complete that evaluation to receive that CEU certificate. I appreciate y'all so much sticking with us through our technical issues this morning. If there were individuals that were watching this together, because maybe you didn't have access to the link or something, so you didn't have a chance to submit your own email and log in. If you will send an email to Bailey Glaves, that email is bglaves@bradfordhealth.net. I also put it earlier in the chat box. If you will send an email to Bailey, he will make sure that you get the link to do your evaluation and ultimately get your CEU certificate. I appreciate again all of you. I appreciate Lynn and Adam for a great presentation, and we hope that you will join us for future topics, and I hope you all have a great remainder of the day. Bye.